The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day, everyone. So welcome to the Pearls part of your Micro and Para lecture. So we're down to our last few days before the big day. So for this session, we will be going through some of the concepts that we have already discussed in the previous lecture. And let me also introduce a little bit of new information as well. Okay, so we'll be going through the generalities, bacteria, fungi, viruses, and then the parasites. So for today's session, ano ba yung mga goals natin? Other than reviewing the concepts that I mentioned na gusto natin i-solidify talaga yung knowledge natin, I also want you to practice answering the questions. It would be good if you've already gone through the handout and you were able to practice or try answering the questions. Bakit? Because we also want to develop your test-taking skills. That's also one way for you to see paano ba yung naging thought process ninyo behind the question. And as we are going through the discussion, you will be able to learn na, dito ako nagkamali or paano ba tayo nagkamali and how were we able to arrive at the right answer. Okay? So that's also one thing na gusto ko sana na i-practice ninyo. Okay, so without further ado, let's proceed with the first question. Question number 1, let's start with the basics. So which of the following is correct with regards to gram staining? So let me just pause for a bit, for the interest of time. You can pause the video for a little bit if you need more time to analyze the succeeding questions and the choices. So for this item, the correct answer is letter C. Gram-negative organisms will appear purple after the addition of iodine. So bakit? So choice letter A, gram-positive bacteria appear colorless after the addition of the decolorizer. So tama ba yun? Wrong. Because you know that gram-positive bacteria, even when you put the decolorizing agent there, it will not lose its color. Okay? It will retain the color purple there. Safranin functions as the mordant. That's wrong because safranin is your counter stain. And lastly, letter D, gram-negative organisms, they turn red upon decolorization. Wrong. They only become red when you add the counter stain. So let's review the procedure. So makikita natin dito, So you have your crystal violet, And crystal violet is your primary stain. Whoops. Okay. So crystal violet is your primary stain. This is followed by your mordant. So the mordant in this case is your iodine, yung grams iodine na tinatawag. And that functions for increasing the affinity of the primary stain to the cell wall. Okay? So makikita natin, at this step, lahat sila color purple. Even the cocci there, the rods there, all of them are color purple. So it will only matter, it will only make a difference kapag inad na natin yung alcohol natin, the acetone alcohol, which is your decolorizing agent. So the gram-negative organisms, they would lose their color and they would be colored by the counter stain or your secondary stain. Okay? So let's go to question number 2. Which of the following is not an acid-fast organism? So whenever you're answering questions, my advice also would be to take note of those qualifiers. Yung mga except, yung mga not, all are ganito, except ganito. Because that's the oldest trick in the book, but sometimes we still fall for it. Kahit ako personally, when I'm answering exam questions, palagi pa rin ako nalilito na parang pag after the exam lahat tayo, ay ano sagot niyo dito? Hindi ba B? Hindi ba B? Except pala yung tanong. Okay, so maganda i-mark na rin natin siya para at least hindi natin makakalimutan. Okay, so when we think of acid-fast organisms, the first thing that comes to mind is Mycobacterium. Correct, di ba? But there are other organisms that are also acid-fast or partially acid-fast. And some of them would include Cryptosporidium, So si Cryptosporidium, ito yung tinatawag nating coccidian parasites. Do you remember them? Yung mga coccidian, So sino-sino sila? Si Cyclospora, kasama na din dyan si Isospora. Okay? So Cryptosporidium, would be one of them. Next, Nocardia, and then you have Rhodococcus as well. So the correct answer is actually letter D, none of the above, no? Kasi which is not daw eh. So lahat sila oo. So the correct answer here is dog, none of the above. Okay. So other examples of acid-fast organisms, you have Legionella, no? It could also be acid-fast. Your Gordonia, your Tsukamurella, yung mga mas weird, mas mga rare na organisms. Okay, so letter D, none of the above. So now we go to your acid-fast procedure. So paano ba na yung mga step-by-step na to? So first, you have your primary stain, which is your carbolfoxin. No, in this case, no, ang mordant natin, hindi siya chemical. You would notice that your mordant is heat. No? So we call it a physical mordant. Okay? So physical mordant siya. Because there is also actually a chemical mordant there, but it's already incorporated in the stain itself, no, yung phenol. Okay? Hindi naman ganun ka-important. So next, you have your decolorizer. The decolorizer in this case is your acid alcohol. So remember, no, mas strong yung decolorizer natin because acid-fast stains, di ba, mas hirap yung kapit niya. So acid alcohol. And then lastly, counter stain in the form of your methylene blue. Okay? So review the steps. Baka malito sa mga simple questions pa madali, sayang, no? Number 3, which of the following is unique to the gram-positive cell wall? So alam nyo na to. This is none other than letter A, teichoic acid. I'm going to show you a very familiar picture. Favorite ko to, palagi ko nalang pinapakita para taga sa kaluluwa, hindi na makakalimutan. So you have your teichoic acid over here, di ba? That's seen only in the gram-positive organisms, no? On the right-hand side, you have your gram-negative organisms. Ano naman yung mga unique dito? So you have your lipopolysaccharides, no? And you have a prominent periplasmic space as you can see over here. Alright? So yun naman yung mga tatandaan natin. Question, no? Dagdag ko lang. Meron ba tayong sterols? Do they have cholesterol for your bacteria? The answer is no. Diba? No. Mga prokaryotes natin, they do not have sterols. No? Sterols are important for membrane fluidity, no, and permeability. And your bacteria, they do not have sterols. No? That's a general concept. Except for mycoplasma. Okay? Mga tao, meron ba tayong sterols? Yes, we have. No? So the eukaryotic cells, we do have sterols. We have cholesterol. Okay. So ito naman, this is just to compare, no, the bacterial cell wall with that of the fungal cell wall. So sa fungal cell wall naman na-notice mo ang daming other components, no, yung mga glucans, mannans, no, chitin. And you can see over here, meron tayong ergosterol. The ergosterol here is the sterol component of the fungi, and that is the most abundant sterol in the fungal cell membrane. Okay, so the purpose of this ergosterol is to regulate permeability and fluidity, as with the humans, no? So move on tayo number 4. Which of the following would correctly describe the properties of plasmids? Okay, sige. So go over the choices. Try to answer. Okay, so the correct answer here is actually letter E, all of the above. So letter A, isa-isahin natin, no? So they are capable of independent replication, yes. They are extrachromosomal, no? So remember, di ba mga bacteria, they have single circular chromosome, right? In contrast to the humans, no, yung mga eukaryotes. Eukaryotes, multiple, marami yan, no? Di ba tayo, ano bang chromosome natin? 46XX, 46XY. But for the bacteria, the general concept there is they have a single circular chromosome. But they are able to have extra na chromosomes, no, in the form of your plasmids, no? So they are extra chromosomal and you can actually manipulate them. That's why mga plasmids, di ba, minsan ginagamit natin sila to transfer yung mga genetic information. Okay, so they are amenable to genetic manipulation. So even yung mga development of drugs, di ba? So the way for us to battle those resistant patterns na nakikita natin ngayon, no? So we try to manipulate the plasmids. And lastly, they must be in circular form to replicate in the host. So the correct answer here is letter E, all of the above. So move on tayo number 5, endotoxins. So familiar na tayo. Remember, in the handouts, we have a table comparing endotoxins and your exotoxins. So they are best characterized as, isa-isahin natin, letter A, polypeptides ba sila? Ano yung naalala ninyo sa handouts natin? No, they are not polypeptides because they are actually the lipopolysaccharide component, di ba? LPS sila. They are mostly secreted by the gram-negative organisms. So, hindi tayo secreted by the gram-positive bacteria. And are they highly antigenic? No. Okay, so they are poorly antigenic. So that would only leave us with one answer, and the correct answer is letter D, the lipid A component of the lipopolysaccharide. So if you have choices like this, no, na parang pareho na magka-contrast, likely yun yung isa doon yung tamang sagot, 'di ba? That's part of your test-taking skills as well. So example, sinasabi natin na endotoxins are polypeptides, sinasabi din sa choices na sila ay lipid, 'di ba? Contrasting. It's only one of the two. So therefore, it has to be A or D. Okay? So that would give you at least an idea na baka itong dalawa yung pagpipilian natin. So maghahanap kayo ng ganun sa choices. That can probably help you as well. So puntahan natin tong table. Exotoxins, they are produced by both gram-positive as well as your gram-negative organisms. Nasa pangalan na exo, therefore they are secreted. Endotoxins, nasa pangalan na endo, nasa loob, meaning to say they are not secreted. Endotoxins, they are part of the structure of the cell itself, no? They are the lipid A component of the lipopolysaccharides, whereas exotoxins, they are composed of building blocks of proteins, polypeptides sila. Lagi kong binabanggit dito, 'di ba, na isipin niyo na lang yung example. Meron ba tayong meron ba tayong bakuna para sa sepsis na endotoxin mediated, 'di ba? Yung mga gram-negative organisms natin. Wala namang ganon, 'di ba? So, whereas sa mga gram-positive organisms that produce exotoxin, example, tetanus. Meron bang bakuna? Yes, 'di ba? So you have your tetanus toxoid, correct? So, yun yung iisipin natin para maalala natin na ang exotoxins, isipin nyo rin, tetanus, yes, they are highly antigenic. We have vaccines for them, no? And the adverse effect, no, is high, no? And the fatal dose is low. Okay, don't be confused. Ang sinasabi natin adverse effect, no, iba siya when we are talking about the fatal dose, no? Kasi pag sinabi natin fatal dose, is it high or low? It's low. Because for a low dose, you already have, a drastic response. Okay, klaro yun, ha? So, katiting na tetanus lang, pwede na magkaroon ng mga opisthotonus, di ba, lockjaw, and all of those dramatic manifestations. Okay, move on tayo. Number 6. So number 6, what are highly mobile segments of DNA that can move from one part of the DNA to another? And this can result in recombination between extrachromosomal DNA and the chromosome. So the correct answer here is plasmids nga ba? Technically, the plasmids can be transmitted, no? But they are not technically considered like highly mobile, diba? That's not a description or an adjective that you would use for plasmids. So, hindi, no? Bacteriophages are viruses that are capable of infecting bacteria. They can also transmit genetic information. But are they highly mobile? Hindi din, no? So, how about transposon? So, that would be your correct answer. Conjugation, para siyang sexual contact. So, move on tayo dito. So, we have 3 major ways, no, for bacteria, no, in order to trade or exchange genetic information. So, you have transformation, and the keyword that I always mention is uptake of free DNA. Transduction would be transfer of genetic information through the vehicles, no? Through your bacteriophages. Pwede tanungin sa exam. Bacteriophages are A, bacteria infecting viruses. B, viruses infecting bacteria. Viruses infecting viruses. Pwede kayong lituhin ng ganon, right? So, don't be confused, no? So, bacteriophages, they are viruses that infect bacteria. Conjugation, yun pa, sinasabi natin para siyang sexual contact. Okay? There is a conjugative bridge. So, pag titignan natin dito sa picture para madaling maalala, when we say transformation, kinukuha lang niya yung free DNA, no? So, inuptake lang niya. So, the free DNA is already present there, probably because another organism already died, tas na-release yung genetic information niya, kinuha ng iba. Lang example ko dito, 'di ba, when you're playing a video game, 'di ba, pag pinatay mo yung monster, lalabas yung loots, pupulutin mo, kukunin mo, 'di ba? Transduction. So, transduction naman may mga vehicles tayo, no? Ayan, no? Yung nasa loob, yung letter S yan, that's the genetic information. So, may daanan. Sa conjugative bridge naman, yung iisipin natin for conjugation, this one. Okay? So, yan siya. So, conjugation, you can transfer the chromosome or you can transfer plasmid, the extrachromosomal material. Okay? So, let's move on. Number 7. So, identification of bacteria by serologic tests rely on presence of specific antigens. Which bacterial component is least likely to have a useful antigen for serologic identification? So minsan, pwede tayong tanungin ng mga questions na parang hindi masyadong straightforward. Or rather, something na parang hindi yung typical concept, nagigets nyo? Like the previous question. Like this one, medyo, kailangan mo siyang pag-isipan talaga. Minsan may mga ganong questions. But, at the end of the day, huwag kayo ma-intimidate sa ganitong questions. Ako, madalas kasi ako minsan, lalo dati, when I was in college, naalala ko, I always get rattled. If there's a question that I cannot answer, and I can't seem to wrap my head around it, minsan basahin mo lang siya once, tas iwan mo muna. Tapos pag binalikan mo siya, and then it will all start to make sense. Or hati-hatiin mo siya. So this is a rather simple question. In short, sino yung walang antigen for serology? So iisipin mo lang, sino ba yung mga bases natin? Anong parts ba ng cell yung ginagamit natin for serology? So remember, di ba, we have the K, capsular antigen. We have the S, the O, somatic antigen. Remember? And then we also have the H antigen. So, tignan natin dito. So, sagutin muna natin, no? So, you have your answer there, the letter A, your ribosome. So, we have a picture over here. So, yung K na sinasabi natin, that refers to the capsular antigen. You have the O somatic antigen, and then you have the H antigen for your flagella. So, therefore, your ribosomes, most likely, wala talaga silang, tawag dito, hindi sila serologic target. Okay? You don't form antibodies targeting the ribosomes. Alright? Number 8 is another similar question, no? Yung parang kailangan mo pag-isipin kasi hindi ganun ka straightforward. Pero pag iisipin mo talaga siya na maigi, ang dali-dali lang naman niya. Diba? So, serologic tests will be most useful in the diagnosis of which condition? So, in short, alin kaya dito yung hindi straightforward yung diagnostic approach natin? If it's something that you can see under the microscope, why bother doing serologic tests, right? If it's something that you can easily culture, why bother? Okay? So definitely gonorrhea and TB, we don't need your serologic test for that, right? You're left with letter C and D, actinomycosis and Q fever. And between the two of them, no, actinomycosis and Q fever, which one do you think is harder to culture? Ang actinomycosis, pwede natin siyang i-culture eh. Okay, so it's actually letter D, Q fever, no? So dito natin siya pinaka magagamit. Okay? And Q fever is caused by your Coxiella burnetii. Okay? So, Q fever, flu-like illness caused by your Coxiella burnetii. Number 9. So, now we go to the cases. So, before we move on, no, so, i-brief ko lang kayo. So, the cases that I placed here are very long. And you would notice I placed there a lot of information. Some of them would be, directly verbatim kung ano yung mga adjectives, ano yung mga qualifiers na ginamit sa Jowetts, or some of them even in Harrison's, to really give you an idea of the picture of the patient. But in real life, hindi pa laging ganun, di ba? So the longer the question, we should feel actually happy when we see a long question. It means to say, there are more clues in the question, right? Rather than getting intimidated na, oh no, ang haba, shucks. In reality, mas maraming information, mas maraming clues. So dito, no, ang point ko lang dito, no, is you can actually use these questions as sort of a reviewer, no? Pero in real life, like I said, hindi laging kompleto yung information. Okay? So sometimes one word or two words, yun lang yung hahanapin mo talaga dun sa buong question. From experience, that's how it used to be, no? So baka ganun din sa mga susunod na examinations. So yun. So, hahanapin talaga natin kumbaga yung mga keywords na medyo game changer talaga or something that would really suggest the disease. Okay? And as we're going along, I'll try to paint the picture as well of the patient, no? Based on how I also experience seeing them in the hospitals. Because sometimes that would also help, no, when you're reading cases na isipin mo siya kung paano ba siya as a patient. Kasi mas madadiagnose mo siya kung iniisip mo siya in the context of a real patient as well. Okay, game, no? So you have a 16-year-old female in the ER presenting with abrupt onset fever, hypotension, and rash. First sentence pa lang, there's a lot of clues already. Fever, hypotension, and rash, no? So something systemic. Nagra-rashes, tapos naga-hypotension. Septic ba to? Diba? She then develops abdominal pain, vomiting, diarrhea. So you already have a dermatologic manifestation there. Now you have a gastroenterologic manifestation. May diarrhea, vomiting na rin. So parang multisystemic, di ba? Next, past medical history as unremarkable. And that tells you a lot kasi you're a 16-year-old female na walang ibang sakit, so bakit ka magkakasakit? Di ba? She also tells you her menses started 3 days ago and is trying out tampons. Okay, so alam na nila yung sagot kasi nabasa nila yung tampons. Pero wag ganun, ha? Baka in real life nga sinasabi ko, baka hindi nila lalagay dyan yung mga buzzwords na hinahanap ninyo. Okay. She eventually improved and was discharged stable. So 1 week later, patient came back with generalized desquamation. So what is the most appropriate diagnosis given this clinical scenario? Answer? So this is none other than toxic shock syndrome. Okay? So fairly straightforward. I gave you a lot of clues there. Okay? But again, in real life, hindi yan ganyan kahaba, hindi yan ganyan kadaming clues. Minsan may mga pampagulong clues pa. So ano kahanapin natin sa toxic shock syndrome? Head to toe ang manifestations. Multisystemic, and usually you don't really have a predisposing medical condition. What would predispose you would be mga behavioral na practices such as use of tampons, nasal packing. Okay, so yun yung mga hahanapin natin. Okay, so usually in previously healthy individuals, wala naman silang other predisposing condition. Okay? So letter C, toxic shock syndrome. Number 10, what mechanism is involved in the patient's case? So kapag TSST ang pinag-uusapan, syempre yung letter C, TSST1 in the bloodstream. Si choice letter A, presence of exfoliative toxin leading to desquamation, that is seen in your staphylococcal scalded skin syndrome. Nadoble na siya. Letter B, release of protein A. Protein A is actually part of the antigenic structure of the organism. It binds to the Fc portion of IgG, so there's really no specific disease associated with protein A. Okay, so hindi natin siya magiging sagot. Letter C is the correct answer. And then letter D, Panton-Valentine leucocidin, they can cause lysis of your WBCs, but they're not really associated with a specific condition. Okay? So minsan, pwede nilang gawin na yung choice A, B, C, and D do sa previous question would match the mechanisms of the choice A, B, C, and D dito. Pwede yon, diba? So now, mako-confuse ka. Kasi kung mali ang question number 9 mo, the next question, mali ka na din, right? So yun, ingat-ingat tayo. Number 11, should the causative agent be isolated? Which of the following is the expected finding? So dapat tama din yung diagnosis natin sa first question, right? So this is none other than letter A. Okay? Coagulase positive because we are dealing with Staphylococcus aureus. Okay? And how do we differentiate staph from strep? Answer? Catalase test. Okay? Catalase test differentiates staph from strep. Okay? So basically, the positive result here is the liberation of the oxygen. So, ano yung magiging positive result na ma-observe natin? It's none other than bubbling or effervescence, as you can see over here. Right? Next, how do we differentiate staph from the other, staph aureus rather, from the other species of Staphylococcus? So that's none other than your coagulase test. And the positive test result here would be a clot formation. Okay, so this one, no? So there's a gel-like clot formation. Let's talk a little bit about MRSA. Okay, so for MRSA, bago tayo magsagot ng MRSA, you want to look for risk factors. Okay? Kasi hindi naman magmi-mirror sa lahat ng tao. Yun yung sinasabi ko sa inyo. Yung previous question, di ba, we mentioned that the patient there did not have a remarkable past medical history. Wala siyang predisposing factors. Okay, pero paano kung previously hospitalized pala siya, multiple hospitalization, or may autoimmune condition, diabetic, no? So yung mga ngayon, mapapaisip ka na, kung paulit-ulit siya na hospital, mag-isip ako, baka pwedeng MRSA siya. Okay? So this one, they are associated with more serious infections, and ang tatandaan natin dito on the micro side would be the reason why MRSA is why a organism develops resistance against methicillin, no? So that's none other than your MECA gene. Okay, so that changes the penicillin binding protein to the PBP2A. Okay, so yung letter A dyan, yun yung palatandaan ko. A for abnormal, PBP2A abnormal, siya yung MRSA. Alright? And the drug of choice, in general, vancomycin. Okay? Staphylococcus epidermidis, no? So this is the normal flora of your skin and the mucous membranes. They can produce biofilms that promote adherence. And you have the poly-D-glutamic acid, which is involved in adherence. So madikit-madikit, dumidikit sa prosthetic devices, no? Indwelling catheters and implants. Okay? So yun yung mahahanapin natin sa choices natin. So, yun yung predisposing factor. For example, if yung case naman natin, 16-year-old female, known case of RHD, already status post, valve replacement, for example, now has a prosthetic heart valve, develops fever. So, yung mga ganun, mapapaisip ka, may predisposing factor, baka epidermidis. Next, Staphylococcus saprophyticus. This one is an important cause of UTI. Keyword, sexually active young women. Okay? And the way to differentiate saprophyticus from the previous organism, epidermidis, is its inherent resistance against novobiocin. Okay? Next. Number 12, you have a 66-year-old male tricycle driver brought to the ER for DOB. So, ako ganyan ako sagot ng question, no? Minamark ko yung mga parang important na the salient points, basically. Kasi kung skip ko muna siya and then later on I will go back to the question, it's hard na if you have to read through everything again and again and again. Diba? Maganda yung meron ka ng kumbagang foundation. No? So, looking at yung mga markings ko, that helps me, kumbaga, at least target, no? Kung ano yung mga salient features niya. So, patient claims to be coughing for the past week with note of rust-colored sputum. Ayan. So, meron na namang description, no? Past medical history, nag-splenectomy. Very important. Chest x-ray, nag-consolidate yung left lower lobe. What is the most likely etiology of the infection? Okay. So, for these questions, no, sometimes hindi naman talaga sila nagre-refer to a specific bacteria but to a group of bacteria. Okay? So, ang question lang, ito, pag titignan mo to, anong sakit ng patient kaya? So, obviously, may consolidation, nagka-cough. Definitely, this is pneumonia. But what type of pneumonia? Is it typical or atypical? So, pag nagko-consolidate na sila, no, a lot of DOB, nagfi-fever, nagsisputum, no, most likely this is typical na pneumonia. And looking at the choices, sino ba yung nagko-cause ng typical pneumonia dito? You only have one there. Okay? And that's none other than your Streptococcus pneumoniae. And another giveaway here is that nag-splenectomy na siya before. Okay? Actually, the age itself, no, ng papasyente natin, it's already pointing towards Streptococcus pneumoniae. Diba? Kaya nga, yung mga elderly patients natin, we vaccinate them with pneumococcal vaccine. Remember, yung PPSV23, PCV13. Okay, so that's already a clue. The rust-colored sputum, that's also used to describe the sputum seen in Streptococcus pneumoniae. And then splenectomy. Okay? Kasi remember, when a patient has splenectomy, the patient will be at risk to develop infection caused by encapsulated organisms. Remember? And you know the Streptococcus pneumoniae is described as a gram-positive cocci in pairs with capsule. That's why if you're going to look at this picture, you would notice that puro pairs sila, di ba? Hanapin natin. Yan, in pairs, in pairs, in pairs. Di ba? Na-notice nyo? And what else? What else can you notice? There is a clear area around the pairs of cocci, right? And those clear areas would represent the part ng capsule. Okay? So, yun yung mga hanapin natin. Number 13, the causative agent above is best characterized as... Sige, look at the choices. Are they part of the oropharyngeal flora? Hindi. Sino yung part ng oropharyngeal flora na Streptococcus? It's your viridans streptococci. Okay? So, ito hindi. This is viridans streptococci. Are they optogene sensitive? Yes. So, correct, no? They are bile soluble. And, of course, they have cell wall. So, mali din to. Okay? You're only left with one answer. And that's letter B, optogene sensitive. So, let's go to this table, no? Remember this, no? Kung may mga biochemical test kayong tatandaan, yung mga common lang naman. Like those tests that would differentiate strep pneumoniae from viridans streptococci. So, sino yung optogene sensitive? Taxo P, no? So, optogene sensitive, taxo P. That's the other name, no? Yung shortcut niya. So, ang palatandaan ko dyan, taxo P, pneumoniae sensitive. Okay? Kung sino yung letter na sinasabi niya, P for pneumoniae, siya yung sensitive. Okay? Kasi ganun din for bacitracin. Taxo A, group A, streptococci naman yung sensitive. Nakuha yun? So, viridans is resistant. Inulin fermentation, positive si strep pneumoniae or fermenter siya. Biosolubility, Positive si Strep pneumoniae or bile-soluble siya. Negative for viridans streptococci. Neufeld-Quellung test is your capsular swelling test. It's a test for capsule. Positive na naman si Strep pneumoniae. Negative si viridans streptococci. So kung nakalimutan, gulo-gulo buhay na, board exam day, no? In a lot of stress. So puro positive si letter P, no? Si pneumoniae, positive siya. Okay? So puro positive letter P si Strep pneumoniae. Okay? Comparing that to viridans streptococci. Si viridans streptococci nasa vivig viridans. So part of the oropharyngeal flora. Number 14. The polysaccharide capsule of the organism above affects host immune response by which mechanism? So, sinabi na niya, di ba? So, sinabi na nung question na, encapsulated yung organism na pinag-uusapan natin. Okay, so dapat coherent din, no? If you have a set of questions per case, no? So you have to make sure na coherent yung mga sagot ninyo. Because sometimes, the succeeding questions, medyo tinutulungan kayo masagot yung mga previous questions. Okay, so anong ginagawa ng capsule? In general, they would retard phagocytosis. Okay? So that's choice letter A. That's in general. Even outside the context of strep pneumoniae, capsules usually, they function to retard phagocytosis. Okay. Next question, ang haba naman, no? So you have a baby boy. Okay, it matters as well, yung age ng patient. That's also something that I'm very particular with because just by the age alone, you can already rule out the diseases that are more common among elderly patients, adults, no? So mas agad natin, narrow down agad natin yung choices natin. Nag-develop ng lethargy, poor suck, poor cry on the third day of life. Ang children, ang baby, no, hindi naman sila nagsasalita. Usually, if they develop poor suck, poor cry, no, baka may infection sila, no, alam mo may sakit sila. Okay, hindi naman sila nagsasabi sa nanay nila na bagong panganak, mama, may lagnat ako, hindi magsasalita yon. Diba? So, yung poor suck, poor cry, ganyan, that's already that's already a big deal. The mother revealed she delivered the baby via VBAC at home. So, the implication nito, madumi, no? Hindi malinis yung delivery. Pwede magkaroon ng infection. The lumbar top, may meningitis pala. Gram-positive cocci. Upon inoculation, perpendicular to a staphylococcal streak, the culture showed an arrowhead zone of hemolysis in what is now the most likely organism. Guys, unang muna kong tanong. Ano ba itong pinagsasabi dito sa second to the last sentence na inoculate daw perpendicular to a staphylococcal streak? What are we talking about? This is none other than your CAMP test. Diba? Yung Christie Atkins Munch Peterson na test. And the positive result with your CAMP test is an arrowhead zone of hemolysis. Remember? So the most likely organism na magpa-positive dyan, si group B, Streptococci. That's your Streptococcus agalactiae. Okay? So ito siya. So that's your CAMP test, and the positive result there is an arrowhead zone of hemolysis, and that's something that you see for Streptococcus agalactiae or group B, Streptococci. Okay. Sige. So, moving on tayo dito, no? Number 16. 6 years later, the boy went to your clinic due to erythematous papules appearing in the perioral area. His mother tells you that the papules became pustules and vesicles with honey-colored crusting. How should you advise the mother now? So first of all, what is the condition, no, of this patient? What's the diagnosis? You have papules, naging pustules and vesicles. There's the buzzword there, honey-colored crusting. So, this is impetigo, right? So, impetigo. Kapag ba impetigo, no? So, if we're talking about impetigo, ano nga bang organism dito yung may kasalanan, no? Which organism is implicated? So, this is none other than your Streptococcus pyogenes. Okay, usually. Okay? So, ano ba yung correct about the sequela of impetigo? Isa-isayin natin. So, her son may present with tea-colored urine as a result of this infection. Pwede, no? Because they can develop post-streptococcal glomerulonephritis, PSGN, no? Which is typically a nephritic type of disease, no? Pag nephritic, mas tea-colored urine, hypertension, hindi tayo nag-expect ng massive proteinuria because that's more of nephrotic with the letter O. Acute rheumatic fever is a common sequela of this infection. Tama ba yun? Impetigo, magkakos ba ng rheumatic fever? Not necessarily. Bakit? Because, di ba, rheumatic fever usually develops more after a throat infection. Okay? So, after a strep throat rather than a skin infection. Okay? How about letter C? she should expect frothy urine due to massive loss of proteins in the urine. Hindi din, because this is nephrotic syndrome. Mali, di ba? Kasi iniisip natin kung PSGN siya, mas nephritic. So, hindi letter C, and definitely it's not all of the above. So, the best answer here is letter A. Her son may present with tea-colored urine as a result of this infection. Okay? Move on tayo, number 17. Now you have an 8-year-old boy referred to you by the PGI assigned at the Barangay Health Center because of a heart murmur. Meron daw murmur. You noted that the joint pain started from the knees, involving the ankles, the hips, then the elbows. So what can you infer? By reading this sentence, ano yung masasabi natin? It's, ano ba siya? Monoarthritis sa palagay nyo? Polyarticular? Is it polyarthritis? So, mas poly siya, di ba? And palipat-lipat siya. So, it's migratory polyarthritis, suggestive of a disease that you know very well, no? So, move on tayo. During this time, the mother also noticed that there were rashes on his trunk that comes and goes. And he also recalled an unremarkable childhood history apart from allergy to penicillin. The murmur was grade 3/6 at the 5th intercostal ICS, no? So, which of the following tests will best support your diagnosis? If so, dapat by now, ano iniisip natin? Rheumatic fever, right? So, sino ba ang nagkakos ng rheumatic fever? So, that's your streptococcus as well. Streptococcus pyogenes. So, which test will tell us that there was a prior strep infection? So, that's none other than your ASO, okay? So, your anti-streptolysin O, that would be that can be requested, and you can check the titers to see kung pwede ba siyang mag-suggest ng previous strep infection. Okay? So, you have the Jones criteria. Jones with the heart there para maalala natin. So, J for polyarthritis, and typically it's migratory. You have your carditis, subcutaneous nodules, erythema marginatum, and Sydenham chorea. Okay, yung chorea, di ba, yung mga involuntary movements, you often see this in young women, no? Mga children, young girls, no? So, mas baka sa pedia natin siya ma-encounter, if not in micro. So, ito yung mga purpose nila, no? ASO would suggest antecedent pharyngitis. Anti-DNase-B, more suggestive of a prior skin infection. Your anti-streptokinase naman, no? So, this one would decrease the efficiency of streptokinase in managing MI. Because back in the day, we often use streptokinase to cause thrombolysis, diba, kung mayroon nag-MI. Although, I think in some hospitals, especially the smaller ones, they might still be using streptokinase. Of course, kung PCI capable naman ang hospital natin, diba? So, we would go for PCI. So, how will you manage the patient above? Okay? So, ano nga uling organism yung pinag-uusapan natin? So, this is a case of Streptococcus pyogenes infection, right? So, magbibigay ka ba ng antibiotic, or will supportive treatment be enough already? Okay, so here, of course, you need to treat the patient. Bakit? Because although you know that rheumatic fever, it's an immune-based disease, no? So, immune-mediated siya, right? But the sooner you get rid of those infection, diba? The organism, diba? You don't allow the body already to mount antibodies further para less na rin yung immune-mediated response, right? So, definitely, we need to treat. But the question is, what antibiotic will you give? So, say for example na lang si BCND pwede. Okay? So, which one would be the best option? Okay? Kasi remember in the board examination, it's not choose one answer. It's not choose the right answer. It's choose the best answer. And sometimes there are more than one correct answer in the question. Okay? So, you have to pick the best one. So, ikaw yung mag-a-adjust. Hindi ka naman pwede mag-shade ng tatlo o ng dalawa, di ba? If there are two correct answers. So, here, the best answer would be letter B, benzathine penG. You give it at 1.2 million units. Okay? So, after you eradicate the infection, no, kapag meron talaga RHD, when there is indication to give prophylaxis, you have to give the benzathine penG every 21 days. Okay, so sa puwet yun, di ba? Tuturok tayo Q21 days. Okay, so do remember that. But for benzathine penG, ang ganda kasi doon is you just give it as one dose, and then that's it. Tapos na. Number 19, true of the sequela caused by this organism. So, Ascough bodies may be found in the heart. Well, pwede. Tingnan natin yung other choices. Rheumatic fever is not typically reactivated by repeated streptococcal infection. Sa palagay ninyo, that's wrong, no? Because chemoprophylaxis is indicated in RF nga, di ba? Kaya nga kakasabi ko lang, you need to give it every 21 days because repeated bouts of rheumatic fever can cause cardiac damage. It can cause acute cardiac damage. Okay? Next, anti-streptococcal chemoprophylaxis is recommended in glomerulonephritis patients. Meron na ba kayo nakitang ganun na tinuturukan sa puwet ng benzathine pen-G because nagkaroon ng glomerulonephritis? Wala, no? Hindi natin ginagawa yun. So that's not recommended. And then lastly, antibiotic treatment does not prevent post-streptococcal disease. Mali, no? Kaya nga tayo nag-treat ng antibiotics, right? Because you want to rapidly eliminate the organism, you want to eliminate the antigen during acute infection. Okay? So, yun yung goal. Rapidly eliminate the antigen. So, the correct answer here is letter A. No? Ascough bodies may be found in the heart of patients with rheumatic fever. So, post-streptococcal disease follows a latency period of 1 to 4 weeks. And the latent period over here suggests that it is not attributable to the disease per se. Diba? It's more of a hypersensitivity response, immune-mediated, rather than the organism causing direct injury. So, rheumatic fever has a marked tendency to be reactivated by recurrent strep infection, while nephritis does not. And that forms the basis why we do not give chemoprophylaxis for those with nephritis. Okay? So, ito maraming nalilito dito. Nalilito din ako dito before, no? So, kailangan talaga paulit-ulit. Okay? Hanggang talaga ma-internalize mo siya. Okay. You want to give chemoprophylaxis kapag rheumatic fever ang pinag-uusapan, but for nephritis, not applicable. Okay, rheumatic fever associated with throat infection, not associated with cutaneous streptococcal infections. Okay? So, antimicrobial drugs have no effect on an established glomerulonephritis and rheumatic fever. Okay? Kung talagang established na. Okay? So, an acute streptococcal infection will require treatment. You either give penicillin, whichever form, whether you want to give it the parenteral, the oral, and you can also give erythromycin. So these are your Ascough bodies. Ascough bodies are seen in the heart of those patients with RF, no? These are perivascular granulomas. They're found in the myocardium. So when you zoom it, no, makikita nyo, may mga maliliit na bilog-bilog dyan, right? Nakita nyo? So ito. Diba? So pag zoom natin sila, there you go. That's your Anichkov cells. No? Bakit tanong sa patho? Malay nyo. Associated to with rheumatic heart disease, they are enlarged macrophages that are found within the Ascough bodies. You also call them your caterpillar bodies. Okay, so caterpillar bodies. Sulat natin para hindi natin malimutan. Okay, move on tayo. Number 20. You have a 25-year-old postgraduate intern complaining of dysuria with profuse and purulent penile discharge staining his underwear. He recalls having unprotected sex with a commercial sex worker. Gram stain of the discharge showed gram-negative diplococci within the PMNs. The most likely organism would have all of the following surface structures except what? So first of all, no, ang dami ng clues. Obviously, this is a case of a sexually transmitted infection. You'll already have your clue over there. Gram-negative diplococci within the intracellular, the polymorphonuclears. So this is none other than gonorrhea. Okay? So actually, fun fact, no, when I was making this question, this was actually based on my experience as a moonlighter. Kasi I recall before, nung nag-moonlight kasi ako, pre-pandemic pa yun. Reflective of my age. So, pre-pandemic yun, I would go on duty dun sa mga companies as a company physician. I really enjoyed doing that kasi it was so laid back. You have the entire day to yourself and, you know, you have a good clinic there, you have a good office, you have a big laptop or a big computer screen. So, nagne-Netflix lang ako buong araw. No? Ang dami kong natapos nun. And you're paid to do that. And I remember during that time, nagbabasa-basa lang din ako ng Harrison's, no? So, yun, parang ginagamit ko siyang study time, luxury time, tapos binabayaran ka. And every now and then, there will be this occasional, employee na magko-consult either for a cough na gustong humingi ng leave ng 7 days or for a penile discharge, no? Yun yung mga common na na-encounter ko. Ang dami talagang may penile discharge. A lot of them would be treated with, the usual antibiotics because they think it's UTI. And then usually, mag-share yan sila na antibiotics. Sabi nila, ininom mo, inom din ako. And it doesn't seem to work because, it's not a simple UTI. It's a sexually transmitted infection, right? So if you have purulent discharge, you don't think of UTI, you think of urethritis. Magkaiba, di ba? And the treatment is different as well. Okay, so that's, life pearls. That's something that you want to share to your patients, no? Because they think it's simple urinary tract infection, but they don't know better. Okay? So kayo yung mag-explain na hindi yan gagaling kung basta-basta ganun lang. So this is a case of Neisseria gonorrhea. And they would have the following surface structures except letter T, W135. That's actually a strain, no? That's a strain of Neisseria meningitidis. So, hindi porket letra-letra, number, part siya ng mga surface structures. So, for Neisseria gonorrhea, you don't really need laboratory confirmation. It would help if you do, but clinically, you can already diagnose it among males, di ba? So, if you want to get a sample from the fetal discharge, then you can swab that, and then you can do a simple gram stain. If you see this in the laboratory, gram-negative cocci in pairs, often described as kidney shape or coffee bean shape, there you have your diagnosis already. For women, it's much more complicated. No, it's not as straightforward to diagnose sexually transmitted infections because you can also have gram-negative cocci in the vagina, diba? Na that's not Neisseria gonorrhea. What's this? Ano yung mga nakikita natin dyan? That's your, That's your violin strings. Remember? And where do we see those violin strings? What condition again? You see it in your Fitzhugh-Curtis syndrome. Okay? So this is the liver. Okay? So on the surface of the liver, it forms adhesions with the undersurface of the diaphragm, right? Forming those characteristic violin strings. And that is seen in Neisseria gonorrhea infection. So, ang tanong sa atin sa number 21, we want to isolate this organism. What culture media should we use? So, in short, anong culture media para sa Neisseria? Answer, Thayer Martin agar, letter D. Okay? So, palatandaan ko dyan, lahat na may Martin, no? So, that's for gonorrhea. So, si Martin Lewis, modified Thayer Martin, no? So, yun. Okay, 22. We have another case. You have a 12-year-old female brought to the ER for a decrease in sensorium, febrile tachypnic, hypotensive. You noted large purpuric lesions all over the body. Sa chemistry, may low glucose, low sodium, and high potassium. What is your most likely diagnosis? So, in shock yung patient natin, may rashes all over, and anong sabi sa atin? Sa serum chem, mababa yung glucose and sodium, mataas yung potassium. Hyponatremic. So, what's happening? What do you think is happening? So, pwedeng nagkakaroon ng adrenal insufficiency. Of course, this is an oversimplification of adrenal insufficiency, right? Okay, pero tawag dito, if you see a laboratory panel like this na hyponatremic hyperkalemia, diba? So example, wala tayong aldosterone. Ano mangyayari? Aldosterone functions to absorb sodium and then it throws out potassium, correct? If you don't have that hormone to throw out that potassium, what will happen to the potassium? It will go up. Okay? But in real life nga, no, yun nga, sinasabi ko, it's an oversimplification of that concept for exam purposes alone. So the most likely answer here is Waterhouse-Friedrichsen syndrome that you see in Neisseria meningitidis. This is a syndrome that's characterized by adrenal apoplexy. Okay? Bleeding into the adrenal glands, leading to secondary adrenal insufficiency. You see those rashes, that's very typical, the mga purpuric rashes that you see in Neisseria meningitidis. And number 23, which of the following conditions may increase the risk of the above infection by 6,000-fold? So, ano yung predisposing factor? Remember, Neisseria species, they are intracellular, right? So, you need a deficiency in the immune system component that targets the intracellular organisms, right? And that is none other than the membrane attack complex, which is basically yung C5b, C6, C7, C8, C9. Okay? So, another way to put it no, is a deficiency in the MAC or the membrane attack complex. Okay? So, Bruton's agammaglobulinemia, this is a deficiency in the, what we call this, antibodies, di ba? Because there's lack of development of the plasma cells, no? So, you don't have antibodies. It's X-linked. Yung letter B naman, yung failure of respiratory burst naman, no? Si CGD or chronic granulomatous deficiency, disease. Si C1 inhibitor deficiency, ito yung may mga hereditary angioedema, no? So, not so for the Neisseria infections. Number 24, in order to prevent developing infection, which regimen must be given to household members and healthcare workers that have been directly exposed to this patient? So, in short, chemoprophylaxis of choice for Neisseria meningitidis. So, ano kaya bibigay natin? Doxy, pwede ba? Hindi, no? Vanco, bakit tayo magva-vanco? Gram-negative nga to eh. Ang vanco only has gram-positive activity, so definitely hindi, no? Yung doxy, mas binibigay natin yan sa mga organisms na nasa latter part ng lecture ng micro, di ba? Yun yung palatandaan ko sa inyo. Usually, the intracellular organisms na mga atypical, di ba? Not for Neisseria, na typical lang naman siya. Okay, so we're left with B and C, no? So, cefuroxime per orem and ceftri. So, the correct answer here is letter C, ceftri single IM injection. Okay? What other alternatives can you give? Okay, so actually, hindi naman first line talaga yung ceftri, but in this set of choices, that's the best answer already. The most common regimen that we give is Cipro. Okay? Very simple to give. Oral lang din. So, ciprofloxacin can be given. Rifampicin can also be given. Okay? Pero wala sa choices eh. So, ceftri na lang. Okay? So, tatlo. Ulit, tatlo. Tandaan na ngayon, Cipro, rifampicin, and ceftriaxone. Okay? Number 25, you have a 7-year-old male who came in with sore throat and nasal discharge. On PE, may thick grayish membrane over the throat and tonsils, accompanied by enlarged cervical lymph nodes. No history of prior hospitalization, no history of vaccination. So what is the most likely etiology? So, sinabi na niya, very important key point here is sinabi niya na unvaccinated yung patient. Okay? Because that already tells you or gives you a clue that we are dealing with a vaccine-preventable disease. Diba? So, isipin mo na lang, sino ba dito yung mga may bakuna? So, meron tayong diphtheria, diba? DPT, Tdap. Okay, so Corynebacterium diphtheriae. Okay? So, ano bang sinasabi natin dito sa enlarged cervical lymph nodes na to? We are talking about the bull neck, diba? Appearance that you see in diphtheria. Okay. 26. What is the mechanism behind the patient's condition? So, answer, letter C, inactivation of the elongation factor 2. There is another organism, no, that inactivates the elongation factor 2, and that is your Pseudomonas aeruginosa. Pakitandaan na ngayon, no? So, pareho sila. Diphtheria and Pseudomonas aeruginosa, they would share the same mechanism. So, that's inactivation of the elongation factor 2, preventing further protein synthesis. Okay? Number 27, possible treatment options na naman. Okay, so letter A, immediate administration of antitoxin. Do we give antitoxin? Pwede, no? Letter B, procaine PNG. Letter C, erythromycin. Siyempre, isang antibiotic lang ibibigay natin, right? What the question kasi is possible treatment options eh. So, parang inclusive, no? So, sometimes you also need to, tawag dito, i-vibe natin yung question, no? Kung saan tayo nililid ng question. So, the correct answer here is all of the above. Kasi we're being asked for possible treatment options. Okay, so si Corynebacterium diphtheriae, they resemble Chinese characters. They have X, L, V, Y forms, and they also have those metachromatic granules or those Babe's Ernst granules. You would notice, diba, sa dulo nila may mga parang protuberant portions, those bulbous ends. Those are the metachromatic granules. And usually, if you use methylene blue, it would highlight the metachromatic properties of that granule. Okay, so how do we culture Corynebacterium diphtheriae? Usually, maririnig mo dyan yung mga tellurite. That's the keyword there, no? Cysteine tellurite, no? Potassium tellurite, basta may tellurite. And then another keyword is Loefflers. Because you know that Corynebacterium diphtheriae, no, is also known as your Klebs Loefflers bacteria, right? So, yun. Pag may mga Loefflers, that's also associated with Corynebacterium. So, it's a heat label toxin. Minention na natin. Inactivation of the elongation factor 2 impairs translocation of the polypeptide tRNA, leading to arrest in protein synthesis. And syempre, kung walang further protein synthesis, necrotizing and neurotoxic effect. Modified ELEC test. This is just a test for Corynebacterium diphtheriae. No? So, this is just of historic interest only. Wala nang gumagawa nito. Okay? Pharyngeal diphtheria, you see those pseudomembranes over there. This one is your enlarged cervical lymph nodes. Ano yun? So, this is your bull neck appearance. And nice to know only, we also have cutaneous diphtheria. So, number 28 tayo, no? The lymph nodes of a 45-year-old male shepherd who died of an unknown disease showed extensive necrosis and hemorrhage with the presence of gram-positive boxcar-shaped and capsulated bacteria. So, what is the most likely diagnosis? So, balik muna tayo sa question. Ano yung mga giveaway dito? Sinabi na niya, extensive necrosis, hemorrhage. Pag narinig mo yan, no, iilan lang naman yung mga bacteria in micro that causes really extensive necrosis, hemorrhage. Ganyan yung description. Think of anthrax, no? And then sinabi na rin niya dito, giveaway, boxcar shape, and it's also an encapsulated bacteria. So the most likely organism here is anthrax or Bacillus anthracis. Okay? Bacillary angiomatosis, sino nga ang causative agent? This is your Bartonella, right? Bartonella bacilliformis. Scrofula caused by your Mycobacterium scrofulaceum, and infectious mononucleosis caused by Epstein-Barr virus. So definitely tanggal na agad to sa choices, di ba? Kasi sabi niya gram-positive eh. So tanggal na agad si infectious mononucleosis. Scrofula, Mycobacterium, hindi naman yung gram-positive, di ba? Acid-fast ang pinag-uusapan doon. Ekis. Bacillary angiomatosis, Bartonella is gram-neg. Ekis also. So, that's also one way to approach the question, no? Sinabi na niya etiology. Check if it's compatible with the choices below. Hindi. So, it's only letter A that's compatible. Number 29, most common form of anthrax is cutaneous anthrax, letter C. Okay? Rarest form would be gastrointestinal anthrax. Si Bacillus anthracis, unique yung capsule niya. Kasi usually ang capsule, guys, diba, they are polysaccharide. Diba? But this one, polydiglutamic acid yung component niya. Okay? And the anthrax proteins, they would have 3 proteins. No? So when you hear these terms, protective antigen, PA, EFLF, edema factor, and lethal factor, think of Bacillus anthracis. Okay? So dito lang tayo makaka-encounter niyan. Okay, so we already mentioned cutaneous anthrax. Maliban dun sa extensive necrosis, hemorrhage, ano pa yung hahanapin nating keywords? Ito, very, very important, pakitandaan. Presence of a black scar. Pakitandaan yan, no? So most likely, anthrax ang pinag-uusapan if the description is a black scar, no? Necrosis. And in wool sorter's disease, ang hahanapin naman natin would be mediastinitis. Okay, so pwede rin magkaroon ng hemorrhage dyan, no? So, yun. Moving on. So, there you go. That's the black scar that we're talking about. And on the left side, that's the culture for anthrax. That's the characteristic Medusa head appearance. Diba? Ito yung pinakagitna. Parang hair ni Medusa daw yung nasa gilid, right? So, that's the Medusa head appearance. Number 30 tayo. You have a 30-year-old male from a nearby town brought to the ER after sustaining multiple injuries and open fractures. Okay, so pag ganyan pa lang, mapapaisip ka na, baka sakit to na has to be transmitted via an open wound, di ba? Kasi otherwise, why would the question mention that? Days after accepting this transfer, the patient complained of pain with foul-smelling discharge and gas bubbles. So pag may narinig tayong foul-smelling discharge, gas bubbles, we think of anaerobic organisms, right? And now you have cutaneous blisters with bluish to maroon colored fluid. So this is basically, ano nangyayari? So this is basically gas gangrene. Okay? So gas gangrene is most likely caused by Clostridium perfringens, the choice letter B. May nagbasa ng libron. Sir, nagbasa po ako ng Jawet. Sabi sa Jawet, sabi sa Harrison's, Clostridium novi is also a causative agent of gas gangrene. Oo nga, pero sabi nga natin, you only choose one answer. You cannot shade two. Diba? Hindi tayo pwedeng bida-bida. Okay? So, ikalma lang natin. So, shade na natin yung B. Lagi nating isipin, ano ba yung mas obvious na choice? Okay? Or ano kaya yung choice na mas alam ng lahat ng tao? Okay? So, letter B, Clostridium perfringens. Very important question, pakitandaan, which virulence factor is associated with the causative agent above? That's none other than your lecithinase. The lecithinase is an alpha toxin of the Clostridium perfringens. Pakitandaan, no? Baka yun yung term na gamitin, no? Alpha toxin, tapos, oh my God, ano na to? Hindi na natin alam. Okay, so lecithinase in Clostridium perfringens. So, this is gas gangrene. Ayan. And notice, no, may mga maroon colored fluid. Okay, there you go. So, gas gangrene. Number 32 tayo. Which statement about gas gangrene is false? So, go over the choices. Okay, so, huwag kakalimutan, di ba? Minention natin at the beginning of the discussion, we said, try to answer the questions, no? Don't just wait for me to give you the right answer kasi sayang. It's also an opportunity for you to practice. So, which statement about gas gangrene is false? The correct answer here, isa-isay na lang natin. Letter A, debridement is needed. Definitely. Check. Sabi false, bilugan natin para hindi natin malimutan. Letter B, hyperbaric oxygen therapy is one of the mainstays of therapy. Meron ka bang kilalang na hyperbaric oxygen sa Philippines? Hindi, di ba? Parang usually sa mga occupational therapy centers lang tayo nakakita ng ganyan. Okay, so baka hindi, no? So baka hindi. Baka ito yung X. But remember, false ang tinatanong. Antitoxins have no evidence of efficacy. parang di naman tayo nagbibigay ng antitoxin sa gas gangrene, no? So baka check. Mixed infection is the rule. Whenever you have anaerobic infections, usually it's a mixed infection. It's very rare that you will have an anaerobic infection that's caused by a single organism alone. Remember that, no? So usually, in addition to your toxigenic Clostridia, there are also various cocci, gram-negative bacteria. Halo-halo na sila dun. Okay? So, sa lahat ng anaerobic infection naman, very important yung debridement, no? You need adequate cleansing, no? You need to remove the foci of infection. Palagi yan. Okay, so that's the safest answer palagi. So, the correct answer here is boy. Okay, kasi we're being asked for the false statement. So, hyperbaric oxygen therapy, although, it seems as if it's the logical choice. Tama? Kasi kung iisipin nyo, anaerobic. Lalagay ko sa hyperbaric oxygen chamber. Hindi ba mapapatay niya organism? It might be, logical, but we don't have evidence for that. Okay? So we don't do that. So that's the correct answer. Okay, ready na ba tayo mag-move on? Next letter, number 33, Okay. Next, you have an elderly paraplegic patient being treated with clindamycin, developed bloody diarrhea, abdominal pain, and fever. Stool guaiac test came back positive. Okay, dito muna tayo. Stop muna. What does a positive stool guaiac test tell you? Anyone? Sige nga. Isipin nyo ulit. So, stool guaiac test is for fecal test, diba? That's the principle behind the fecal occult blood testing. But mind you, no, please do not order FOBT and FIT, fecal immunochemical testing, for your inpatients. No, this is not just me speaking as a gastroenterologist, but even when I was a resident, that's also my pet peeve, because those tests, no, are only validated to be used as screening for colorectal cancer in a patient na outpatient, no? So please, wag niyo nang gagamiting test yung FOBT and FIT para lang to confirm, ay mukhang nagdudugo. Pa-FIT natin or pa-FOBT natin. That's not how it should be done. Okay? And these tests, no, there are a lot of factors also that can lead to a false positive, false negative. Magiging confused lang kayo. Kumbaga, it will just set the stage for a diagnostic trap. Pag nag-positive siya, magpapa-colonoscopy ka. Baka hindi naman talaga indicated to begin with. No? And when it's indicated naman to begin with, kung talagang dinudugo na siya, regardless naman magpapa-colonoscopy ka, even without the guaiac test, right? Okay. So anyway, medyo nag-segue ako doon. Balik tayo sa totoong buhay. Endoscopic evaluation revealed presence of erythema with white to yellowish plaques. What is the most likely cause of this patient's condition? So ano nangyayari dito? This is none other than your pseudomembranous colitis, and that's caused by C. diff infection. Okay? So yung C. diff infection natin, merong severity din yan. Okay? Meron pang fulminant. So by the time na naging fulminant na siya, you will look for yung mga megacolon, shock, no? Yun yung makahanapin natin sa question. So do we need to treat C. diff? C. diff is secondary to an antibiotic exposure, right? The predisposing factor there is the clindamycin treatment. Treatment with clindamycin. So number 34, how should we treat C. diff infection? So you treat it with an antibiotic. But here you have limited choices for antibiotics. So tatandaan natin sila. You can give oral metronidazole. You can give oral vancomycin. Take note, it's not IV because vancomycin is very big. No, it has a large molecular weight. It does not get absorbed. And that's also the very reason why you want to use oral vancomycin para sa C. diff infection. Bakit? Because it does not get absorbed. It stays where it should stay. Your concern naman is its properties within the lumen. Tama? So you don't need it to be absorbed. And then lastly, fidaxomicin, you can also use that. Okay? Actually, we want to shy away from using metronidazole nowadays already. No, mas gusto natin yung fidaxomicin or oral vanco because less chance of recurrence as well. But it's not always available. So a lot of times we still give oral metronidazole. So the correct answer here is letter D, A, and C. I hate these types of questions, but unfortunately, sometimes they still appear in the exam. Okay, so dapat sanay pa rin tayo magsagot ng ganyan. Number 35, you have a young man from Cavite sustaining multiple injuries. You opted to see a faith healer, nag-apply na macerated leaves. Ano kayong implication nun? Exposure, no? So I would want to think of a condition na natatransmit through open wound. Nagkaroon ng painful muscle spasms in the legs and in his jaw. Went to the ER because of difficulty opening his mouth. So what is this condition? Very straightforward. Tetanus. Okay? And the usual first thing that you see here is trismus, no, in lockjaw. And tetanus, what is the pathophysiology behind tetanus? Remember, in tetanus, it's because of failure to release the inhibitory neurotransmitters. Correct? Sino ba yung inhibitory neurotransmitters? You have GABA, glycine. Ano ba yung mga excitatory na neurotransmitters? Example would be acetylcholine. Okay? Inhibition of the release of those excitatory na neurotransmitters such as acetylcholine. That's something that you see for botulinum. Okay? So for botulism. So therefore this is not for tetanus. Okay? So there are different steps in the pathophysiology of tetanus, and these are as follows, except for letter B. Okay, inhibition of the release of acetylcholine, because that's something that you see in something that you see in botulism, not in tetanus. Okay. You have here the very classic picture of a man who is arching his back, flexing his muscles, and merong plastic na smile, no? The devil's grin or the risus sardonicus. So this is what you see in tetanus. Okay? And don't forget, no, in tetanus, it's not just really about the flex, no? There's also a lot of dysautonomia happening there. That's why a lot of these patients, no, I mean, really, actually, all of them, they have to be admitted at the ICU because you need to monitor their blood pressure, you need to monitor their heart rate, SATs, because the BP can be labile. 1 minute it's up, the next thing you know, it's down. And then they would also have those spasms. They have to be kept in a room that's quiet, no? Hindi sila na-excite, na wag ka rin masyadong happy kapag pinupuntahan mo sila na, good morning, doctor, ganito po, ganyan-ganyan. Wag ka masyadong masaya, di ba? Kasi when they get startled, no, it can also trigger what they call this, a spasm. Okay, so yung mga ganun, no? So ICU setting sila. Okay? So kung yung question sa board exam, not too much on the spasms, not too much on the paralysis, no? The spastic paralysis, you also want to look for dysautonomia. Okay? Sadly, mga babies then, they can also have tetanus, especially in the context of, di ba, yung mga delivery na hindi sterile, usually kapag sa bahay lang pinanganak, ginupit ng gunting na panggupit ng kartolina, no? So yun, pwede rin tayo magkaroon ng neonatal tetanus. Okay, even animals, nice to know, cute na cute lang ako dito, kaya sinama ko siya dyan, no? Even animals can also have tetanus. They can also have those, the arching of the back, no? Opistotonus. Okay, so how do we differentiate these different organisms? No, you want to look at the position or the placement of the spores. If it's round and terminal, that's for tetany. Terminal, tetany, no? Yan ang palatandaan ko. Tennis, di ba? Puro te, no? Tennis, terminal, tetany. Si botulinum naman is subterminal. The difference there is very subtle. It's just a little below the end. Di ba? Na-notice niyo sa picture? Si Clostridium tetani, para siya talagang lollipop, drumstick, diba? Pero si botulinum, nandun na sa dulo, but it's just a little below it, no? Perfringens naman, depende, no? So, when you grow it on culture media in the laboratory setting, usually they do not form spores and you don't appreciate the spores. Okay? Si botulinum, ano nga yung difference nito? Kasi kung kanina spastic paralysis, no? Ito naman, flaccid paralysis. That's the keyword there. So, limp. No? Yung baby floppy, limp. And classically, this is associated with ingestion of what food? Honey. Remember? No? Si Clostridium botulinum, yung mga delata, no? Honey sa babies. And then the babies, they come out limp. No? So, yun siya. Number 36 tayo. You have a 26-year-old male ordering a plate of oysters at a bar in Makati, days later admitted for fever and chills, hypotensive, and you also have hemorrhagic bullous skin lesions with necrosis and sloughing. Okay, so ano kaya nangyayari dito, no? So may necrotic lesions daw yung patient, febrile, hypotensive, nagsashock. Gram-negative organisms daw with a single polar flagellum. Very, very easy. So, ibig sabihin, Vibrio yung pinag-uusapan, no? Gram-negative na curve na may single polar flagellum. This is none other than Vibrio vulnificus, letter D. Okay. So, bakit hindi si Vibrio cholerae? Vibrio cholerae mas diarrhea, even for parahemolyticus. Alginolyticus, the same, no? Pwede rin sa mga seafood. But pag oysters kasi mas vulnificus tayo. No? So that's your clue there. And the manifestation. Usually, when you ingest oysters or when you handle oysters, so both are possible routes, no? When you handle them or when you ingest them, pag nasugatan, no? So yun, yung pag meron tayong bullous skin lesions, that's very suggestive of Vibrio vulnificus infection. So do remember that. Okay. Number 37, all are true of Vibrio cholerae except. Paano kung ikaw yung nagsasagot ng question na to, no? Tapos, magkakasama sila 36, 37, 38, for example. Tapos yung 37, biglang all are true of Vibrio cholerae, mapapaisip ka tuloy. So, mali ba yung sagot ko kanina? Yung 36, Vibrio cholerae ba yung burahin natin? Okay, so careful with that. If you're sure of your answer, then go for it. Okay? Trust your instinct naman, no? Trust your own judgment. Wag porket minention dun sa next question na all are true of Vibrio cholerae, babaguhin mo na yung una mong sagot. If you're sure of it, go lang. Okay. Pero, syempre, of course, that should also alarm you, di ba? That should also parang tell you na to do a second look. Kasi baka may na-miss out tayo. Number 37, all are true of Vibrio cholerae except letter A, increased levels of CAMP resulting in hypersecretion. That is correct. Usually in Vibrio cholerae, there's profuse diarrhea, there's rice watery stools, but parang wala namang maraming RBC at WBC, di ba? Because it's a toxin-mediated disease. It's not direct invasion. It's not inflammatory talaga, no? Therefore, kung toxin-mediated, usually bland, walang laman. Okay? So, oral doxy is indicated. Definitely, we need to give antibiotics for those with cholera. So, the correct answer here is letter C. Analysis of rice water stools will reveal numerous RBCs and PMNs. Okay? Move on tayo number 38. We want to culture Vibrio because which one can we use? So, it's letter C, pakitandaan na, thiosulfate citrate, bile, sucrose, agar. Okay, so it has a high pH that enhances the growth. There are also several transport media that you can use, no? So, one of them would be alkaline peptone water or alkaline peptone broth, no? So, yung APW. So, TCBS, kapag na-ferment yung sugar, naging yellow. So, that's something that you see in Vibrio cholera. Rice water stool on your left. Ito, sabi ko, di ba, bland, no? Usually, kapag toxin-mediated, it's very bland. Not much on the red cells, WBCs, no? Mas watery lang talaga. And of course, as a sequela of it being really, really watery, pwede na tayo magkaroon ng electrolyte imbalances. Vibrio vulnificus infection, those hemorrhagic bullous skin lesions. Number 39, you have a 9-year-old male coming to the emergency department due to fever of 7 days duration. The child was complaining of abdominal pain with multiple episodes of loose stools. The mother tells you that her son has been picking on the bed sheets and appears to be talking to somebody. So what is the most likely organism implicated in this case? Guys, ito yung isa sa pinakamahirap na set of questions, yung mga diarrhea. Na yung mga loose stools. Because there are really very fine details lang talaga na mag-separate sa kanila. Of course, again, like I said, itong mga questions dito, nilagyan ko ng maraming information para maging sort of reviewer nyo nga sila. Na at least you would have a mental picture of how a patient with this condition looks like, no? How they will present, but it's not always the case for your board exam. So kapag yung kanina nga, watery, you think of cholera. But this one, ano yung mag-differentiate sa kanya from the other conditions? Look at the first highlight over here. Underline pala. Fever of 7 days duration. Matagal yun, ha? Diba? Kayo ba nagka-diarrhea na? If nagka-diarrhea ka na before, usually you would have fever for a day or two and then it goes away, right? Then the diarrhea remains and then it would go away after a day or so as well, right? Pero kung 7 days yung fever mo, prolonged fever, mapapaisip ka. So you want to look for an organism here, no, that would present with prolonged fever. Correct? Tapos, merong neurologic manifestation. May pagpapick ng bedsheets, tapos may kausap ka. So this is what you call the coma vigil, no? So this is something that you see in Salmonella typhi. Okay? So this is none other than typhoid fever. Yun, no? So meron tayong tinatawag na muttering, delirium, and coma vigil. So actually, itong mga bagay na to, sa Harrison's ko to nabasa eh. Pero, very useful pa din siya kasi yung micro natin, no, it really encroaches on the infectious disease aspect of Harrison's, of internal medicine. Okay? So pag ganun, prominent ang neurologic manifestations, prominent ang fever, may abdominal pain, you think of Salmonella infection. Alright? Remember, sa typhoid fever, it's not diarrhea. That's the most prominent symptom. The most prominent symptom is prolonged fever. Tapos part din dun yung abdominal pain. Okay? The diarrhea in salmonella infection is not really, distinguishing feature. Kasi in salmonella, you can even have constipation. Number 40, in relation to the case above, what is the most appropriate sample to be collected during the first week of illness? Answer is blood. Okay? So this one actually medyo na ano na to, no? What do you call this? Medyo na obsolete na, di ba? Yung what sample will you collect at the first week of illness, second week of illness? But let me just mention it for board exam purposes. Okay? Si bone marrow, very useful at any point of the illness. It can give you a good yield. The yield is not affected by antibiotic treatment, initial antibiotic treatment. So, yun yung mga advantages of doing bone marrow sampling. But of course, who will do a BMA para sa salmonella infection? Napaka-impractical. Okay? But for board purposes, bone marrow samples, useful at any point of the illness. Number 41, what is the most prominent symptom? Kakasabi ko lang, the answer is prolonged fever. Intestinal perforation and bleeding, pwedeng mangyari sa salmonella. Okay, that's not something that's typical for other causes of diarrhea. So kapag yung pasyente mo parang acute abdomen yung presentation, guys, that should make you think of salmonella. Klaro? But this one usually happens by the 3rd or 4th week of illness. So that's also something that you want to look at sa question natin. Kung kakastart pa lang na ab pain, parang acute abdomen na, mapapaisip ka, baka hindi naman salmonella. Okay? So these are your Peyer's patches. And what do you call this? Si Peyer's patches, ito yung site kung saan pumupunta si salmonella. Okay? Pag tinanong tayo, guys, where does salmonella go to establish carrier status? It's not the Peyer's patches. Ngayon naman ang sagot ay gallbladder. Okay, pakisulat para maalala. Kapag carrier status ng salmonella yung pinag-uusapan, that's the gallbladder. And pwede rin kayo itanong sa board exam, which among these infectious agents can cause a calculus cholecystitis? Okay, a calculus, meaning to say walang bato pero namamaga yung gallbladder. So salmonella is one of the causes of a calculus cholecystitis. Leptospirosis also would be a cause for a calculus cholecystitis. Okay? So, between one over the other, knock on wood, what if both of them appear in the board examination? Unfortunately, I do not have an answer for that as well. Because there are really no evidence, no written statements anywhere I look, no? Comparing carrier status, yung incidence ng calculus cholecystitis, ng leptospirosis and salmonella, it's really hard to compare, no? So, hopefully, let's just pray na they don't come out na both sila nasa choices. Okay? Because both are possible answers. Si Typhoid Mary, nice to know lang naman, no? So, siya yung notorious na carrier ng salmonella. Number 42, if this were to be a case of salmonella infection, which of the following will be seen upon biochemical testing? Napapaisip ka ngayon, wait lang, convinced ako na salmonella to. Bakit mo sinasabi sa number 42 na if this were to be a case of salmonella infection, ibig bang sabihin, hindi. Baguhin nga natin, palitan natin. Okay, so dyan tayo madadali. Okay? So if you're sure it's salmonella and then you have a statement like this, then trust your answer. Okay? Pero kung of course, pag may ganito kayong statement, like I said, you want to go over your previous answers as well. Kasi baka may na-miss out ka. But if sure ka, go lang. Okay? Which of the following will be seen upon biochemical testing? The answer here is lactose negative, H2S positive, glucose positive. Okay? So, yun yung key feature ng salmonella, it is H2S positive. No? May black discoloration when you culture it. Lahat ng enterics, glucose positive. Remember that. So, even si Shigella, I always say that Shigella is tamad, right? Shigella is tamad, hindi siya nagpa-positive sa mga biochemical tests. But it's still glucose positive because at the end of the day, kapamilya siya. Diba? So, Shigella is still a member of the family Enterobacteriaceae. Letter B, lactose positive, glucose positive with a greenish metallic sheen. Wala nang iba tayong pinag-uusapan dito kundi E. coli. Okay? Next, urease positive, phenylalanine deaminase positive. No, ano kaya to? So this is none other than your Proteus, Providentia, and Morganella, ppm. And then lastly, lactose negative, mannitol negative, H2S negative. Ang tamad mo naman, lahat na lang negative. Non-motile pa, dagdag natin dito, no? Non-motile. So, this is your Shigella. So, for board exam for purposes, no? I just want you to be familiar with the rapid lactose fermenters and the non-lactose fermenters. The late lactose fermenters, nice to know. Okay? So, rapid lactose fermenters, madaling maalala, Eke, Escherichia, Klebsiella, Enterobacter. Ang pangit pakinggan para maalala. Non-lactose fermenters, SSPBM, no? Salmonella, Shigella, Proteus providentia, Morganella. Okay? The late lactose fermenters are specific species under Salmonella and Shigella. Not so important. Skip na natin yan. Okay, so that's your greenish metallic sheen. And this one over here, that's the culture media of a patient na pinagkunan ng Klebsiella, no? So you would notice it's very mucoid, it's very sticky. When you put your finger there, parang didikit siyang ganun. So that's Klebsiella pneumoniae. Okay, malagkit, madikit. Si Salmonella and Shigella, key feature, key defining feature here would be the presence of your H2S. Diba? Na-mention na natin to. So H2S positive. And then this one, H2S negative. Okay, so Shigella. Okay. Okay, so number 43. Puro cases, no? Pero guys, alam nyo, sulit na sulit mag-aral ng micro. Walang lugi dito. Kasi yung any specialty you go into someday, okay, if you're pursuing a specialty, you want to go to IM, you want to go to surgery, kahit saan ka pa magpunta, guys, 100% sure ako, merong infectious agent dyan. Right? Magagamit niyo yung knowledge ninyo sa microbiology. Kaya sulit siya talagang aralin. And even for the board exam, no? May infectious agent. Charot. So, even for the board exam, what do you call this? If it doesn't come out in micro, chances are, it can come out in IM. It can come out in pedia. Diba? For all you know, it can even come out in PrevMed. There was a time in PrevMed namin, puro TB at dengue. Like, ano ba? Diba? Naging extension ng micro. So, you really never know. Kaya sulit na sulit siyang aralin. And minsan sa patho, lumalabas din yung mga micro questions natin. Anyway, going back, no, number 43 tayo. You have a 34-year-old male bank teller presented with non-bloody diarrhea for the last 14 hours. Which of these agents would be the least likely cause of the patient's diarrhea? Paano naman yung approach? Pag tinanong tayo ng ganito, mukhang mahirap, no? Kasi iniisip mo, sino yung least likely? Pero, very easy question lang siya. So, in short, sino sa mga organism na to ang least likely nagkakos ng diarrhea? Yun lang talaga siya. So, it's letter C, Streptococcus pyogenes. It's most associated with strep throat, rheumatic fever, di ba? Skin infections. So, mas less tayo dun sa diarrhea. Okay? Number 44. All of the following agents are known to cause diarrhea except same question basically, pero different set of choices. So alam natin si E. coli pwede, Vibrio cholerae pwede. So dalawa na lang, Clostridium perfringens, Enterococcus fecalis. Fecalis, tae, diarrhea siguro yan. C ang sasagot natin na except. Bilugan natin yan. Pero wrong, no? Because Clostridium perfringens can also cause food poisoning. Okay? Other than gas gangrene, if you ingest Clostridium perfringens, you can also have food poisoning and that presents with diarrhea. So the best answer here is Enterococcus fecalis. Okay, so why did I include this question? Because there's a lot of confusion here. Hindi porket fecalis, no, nasa tae, no? Enterococcus fecalis kasi is more associated with urinary tract infections and intra-abdominal infections. So usually this type of infection would happen in the setting of somebody who has, like perforation, biliary infection, dun siya, okay? So, intra-abdominal infection or urinary tract infection. Diarrhea, not so much, okay? So, wag tayo malilito dun. Number 45, among these agents recognized to cause diarrhea, which one has the lowest ID50? What is ID50? That's the infectious dose 50, okay? So, in short, which one has the lowest infectious dose? Answer, Shigella. Okay? Shigella in general, kokonting organisms lang, they can already establish infection. Okay? I wouldn't recommend you memorizing how many organisms are needed to establish infection because each reference would have a different value. Hindi naman life-changing yun, di ba? Kung sabihin kong 50, 100, 1,000, basta ang mahalaga, konti lang ang kailangan. Okay? Next. Ang haba na naman, no? Pero sabi ko nga, pag mahaba, dapat masaya ka. Diba? Kasi kung may hindi ka alam, baka sa last sentence, malaman mo yung sagot. Diba? Next tayo, number 46. You have a 65-year-old male alcoholic with high fever, dyspnea, cough, Curarancelli sputum. Okay, giveaway. May sagot na sila. Pero tapusin natin. Auscultation, may crackles, gram-negative coccobacilli. So what is the most likely organism? Hindi porket Chirancelli automatic Klebsiella, okay? But you would notice macracles, diba? So it tells you na typical type of pneumonia siya, hindi siya atypical. So less likely na ang sasagot natin ay Legionella, less likely na isasagot natin Mycoplasma. Correct? So it's a toss-up between A and B. Now, you would notice patient is an alcoholic. So, ang tawag dito. Tapos, ang sinabi sa inyo, gram-negative Coco bacilli. So, wala nang duda doon. So, the only answer here is Klebsiella pneumoniae. Okay? Because Streptococcus pneumoniae is gram-positive cocci. Pero kahit hindi niya sabihin yung gram-negative cocci, the mere fact lang na sinabi na niya sa inyo, alcoholic, na nag-pneumonia na mukhang typical, macracles, no? It's may Chirancelli sputum, it's Klebsiella pneumoniae. 47, true of the pathogen above. Is it a slow urease producer? Correct, no? So, what if hindi mo alam? Sige, skip mo muna yung letter A. Letter B, has a large capsule with mucoid colonies? Definitely. Because you know that Klebsiella pneumoniae has a very big capsule, correct? So, therefore, it can cause mucoid colonies, madikit. And letter C, rapid lactose fermenter. Naalala nyo, eke, di ba? Pangit pakinggan para maalala. Escherichia, Klebsiella, Enterobacter. So, you have already 2 out of the 3, therefore, it's all of the above. Okay? So, 47 is dog, all of the above. Okay, let's move on. Number 48. Now you have a 9-year-old boy who developed abdominal pain, low-grade fever, and 5 episodes of bloody stools. Bilugan natin. So, sinabi niya kumain daw ng hamburger. Porket nabasa yung hamburger, may sagot na sila. Pero tapusin natin. Persistence of diarrhea prompted admission. On initial examination, patient was febrile, hypotensive, tachycardic, and weak-looking. Tenderness in the lower quadrant. Anong meron sa CBC niya? Ay, bakit ang baba ng hemoglobin mo? Platelet, 95,000 ang baba-baba din. So, what is the most likely agent causing the patient's illness? So, this is a case of, ano to guys? Nagdudumi ng dugo, tapos anemic, tapos thrombocytopenic. So, this is none other than enterohemorrhagic E. coli causing hemolytic uremic syndrome or what you call HUS. Okay? So, in hemolytic uremic syndrome, it's a triad, diba? Hemolytic, so hemolysis. Uremic, mataas ang kreya, diba? Tapos, thrombocytopenic din sila. So, therefore, EHEC dapat ang sagot. Hep, walang EHEC sa choices. So, which one would be the best answer? EHEC is also known as your VTEC and your STEC, the Shiga toxin or the verotoxin producing E. coli, no? So, the answer here is B, boy, no? So, yun. Move on tayo. Traveler's diarrhea, no? Yung turista. Okay, yung tinasabi nilang turista. Traveler's diarrhea, this is your enterotoxigenic E. coli. Diarrhea in children and flattening of the villi promoting malabsorption, this is EPEC. So, yun yung clue natin sa EPEC, ha? Usually, this would happen sa mga institutionalized, no? Yung mga home for the aged, daycare center, no? So, yun. Bloody diarrhea invading the mucosa. Nandun na yung keyword, invasion. So, AYEC, no? Enteroinvasive E. coli. And then lastly, dysentery, Shiga-like toxin causing hemolytic uremic syndrome, and they are unable to ferment sorbitol. So, this is EHEC, STEC, or VTEC. Okay? So, the question is, the organism above causes disease by which mechanism? Sagot, letter D, no? So, production of cytotoxic Shiga-like toxins. Nasabi na natin. Okay? Attachment and effacement. Sino kaya pinag-uusapan natin dito? Kapag flattening of the villi, this is none other than your enteropathogenic. Activation of adenylyl cyclase. This is your toxin-mediated, no? So, ETEC, turista, or traveler's diarrhea. Invasion of the intestinal mucosal epithelial cells. So, this is none other than AYEC or enteroinvasive E. coli. Okay? So, let's go to number 50. Okay. Sige. So, number 50, you have an 18-year-old student presenting with high fever, painful enlarged nodes in the neck, groin, and axilla. Aspirate from the enlarged nodes revealed bipolar staining. So, which of the following is responsible for transmitting the organism or the infection to man? Ano sagot? So, eto, ano bang kaso to? Buboes, no? Pag narinig yung term na bubo, sino ba naiisip ninyo? Okay, so this is your Yersinia pestis, right? So, Yersinia, meron bipolar staining. That's another clue. But of course, remember that bipolar staining is not specific for Yersinia. It's there are a lot of organisms with bipolar staining. So don't be, tempted na Yersinia agad. So what is the vector for Yersinia? Marami nagkakamali kasi meron silang acronym na mnemonic na Yeye the rat. Yeye the rat. Saka Yeye the rat, nagkakamali tuloy. Rat ang sagot, no? Remember, the rat will not bite you to give you the infection. It's the flea na nasa rat. Okay? So, fleas yung vector natin dito. In particular, yung Xenopsila cheopis. Okay? So, the correct answer is letter B, fleas. Okay? So, yan, no? So, back in the day, dami-dami namatay yung Black Death. Okay? Because of plague. And those are the buboes, no? So, ito yon yung safety pin appearance. Can you see? Mukha siyang safety pin, right? Okay, siguro sa antok nyo nagmumukha ng safety pin, no? So, yan. Pag nakikinig ng lecture, tapos kinukuha na ng liwanag, ay, safety pin. Okay, nakikita nyo na siya. Pero diba, mukha naman. Okay? Sige, so safety pin appearance. So, other than that, sino pa yung ibang safety pin appearance? You have Pasteurella multocida as well, no? Even, what we call this, yung causative agent ng donovanosis, no? Si Calimotobacterium granulomatis. That also gives you a safety pin appearance. Okay, number 51 tayo. Move on tayo, Which organism is most commonly isolated in lesions involving human bite wounds and fist fight injuries? Okay, so nagkagatan, nagsapakan. Okay, so anong kaya yung causative agent? It's none other than your Echinella corrodens and also gives you a bleach-like odor. Okay, amoy Zonrox daw. Okay, so Echinella corrodens, it's also known as your corroding bacterium. Bakit kaya siya tinawag na corroding bacterium? Because it pits or corrodes the agar. Okay? So, that's your corroding bacterium. Okay. Next item tayo, number 52. So, here you now have a 30-year-old firefighter admitted at the ICU after sustaining burn injuries while on duty. Okay. So, nagka-burn injuries daw. Several days later, nag-fever, nagkaroon ng wound na may greenish discharge and fruity odor. There were black necrotic lesions noted with surrounded by erythema with no pus. Nagka-underline pa ako, lahat naman in-underline ko na, no? The exotoxin A produced by this organism mainly acts by which mechanism? Okay, so if you've experienced going on duty sa mga burn units, you would notice na pag pumasok ka sa burn unit or sa ICU even, no, may maamoy ka talagang kakaibang odor. 'Di ba? Meron siyang amoy, parang langhap sarap. 'Di ba? Alam mo talaga na nasa burn unit ka. And then yung mga wound nila when you remove the gauze, 'di ba may mga greenish discharge talaga. Okay, so at least from my own experience as an intern, no? Kasi kami before may burn unit rotation kami, tapos ang tawag namin doon car wash kasi 'di ba huhugasan mo sila everyday para kang nagka-car wash, palit-palit ng gauze and everything. And may odor talaga. Honestly, I wouldn't call it fruity, but there is a distinct odor, right? That's because of the 2-aminoacetophenone, because a common organism seen in this population of patients is Pseudomonas. Okay? Ano naman yung sinasabi niya na black and necrotic lesion? This black and necrotic lesion here, it's actually one of the things that would differentiate Pseudomonas infection from other infections. No? That's what you call ecthyma gangrenosum. Okay, sulat natin para hindi natin makalimutan. Kung hindi man lumabas sa sa micro, baka lumabas sa IM. No? So that's what you call ecthyma gangrenosum. Okay. So, in short, tinanong ko na to kanina, di ba? Exotoxin A produced by Pseudomonas acts by what mechanism? Letter B. Elongation factor 2. No? So, blockade of the elongation factor 2 inhibiting further protein synthesis. Okay, next. Number 53. Which of the following statements correctly describes the causative agent above? So, si Pseudomonas daw, no? How will we describe Pseudomonas? Guys, isa-isahin natin, ha? Letter A, rapidly ferments lactose. Parang mali, no? Bakit? Because you know that Pseudomonas is one of the most common non-fermenters, no? It's a non-fermenter. So, X agad ang letter A. X! No, ganyan. Ako dati, no? Sobrang bida-bida ko talaga, no? Naalala ko dati. Alam mo, minsan talaga may, may topak din ako. I remember before, pag nag-answer ako ng exam, may dala akong pentel pen, no? Kapag feeling ko na hindi yan yung sagot, shade ko ng pentel pen, never to be seen again. Next, not able to grow at 42 degrees Celsius. Wrong! X! Okay? Bakit? Because it's able to grow at 42 degrees Celsius. Okay, so yun, minamark ko yung yung paper ko sa board exam. Huwag niyo akong gagayahin. Minsan, alam mo, nabobore lang siguro ako, no? Tapos nadala ko kung ano nung highlighters, no? Nag-highlight din ako ng questions sa board exam. Ganon. No? Pero yun, tapos na-realize ko nung later on, sabi ko, shucks, gusto kong balikan yung mga pinentel pen ko. Wala na, hindi ko na mabalikan. Kaya yun, tinigil ko na rin naman siya, guys, no? So, yun. So, letter C. Ay, tapos, eto na, nagsimula na ako magkwento eh. Magkikwento na ako, itutuloy ko na. Naalala ko rin when I was in med school, no? When I was cramming, no? Kapag nandun talaga ako sa absolute life and death cramming situation. Especially sa mga biochem exam, Lord. Biochem. No, yun ang pag first reading and last reading na lang talaga. Kung isang reading na lang talaga, isang pasadahan na lang ang kaya mong gawin dahil wala ka ng time, pinepentel ko rin sila. Na para talaga mapilitan ako, natatandaan ko to bago ko yan strike out, sabi ko. Aanuhin ko yan talaga. Kailangan ko siya maalala para ma-force ka. Yun. That's only good for 15 minutes. Diba? After the exam, wala na. Deleted na rin yung information. Ayun. Wala lang. Yung mga quirks ko lang yun before. Yun. Pero ngayon, hindi ko na siya kayang gawin. Kasi, signs of aging, mahina na rin yung short-term memory. Anyway, letter C. Neutropenia is a risk factor for developing bacteremia. Check, definitely. Okay? Actually, before, what do you call this? For Pseudomonas, you would really want to look for those predisposing factor, no? Yung neutropenia, no? So that's one, yung mga diabetes, no? Other chronic conditions. Dati yun yung mga hinahanap talaga natin. Okay? But nowadays, even if wala talaga silang predisposing factor, they can really still develop Pseudomonas. CFTR gene mutation is protective? Mali, no? CFTR gene mutation is what you see in cystic fibrosis. And guys, actually, di ba yung mga patients with cystic fibrosis, they can develop Pseudomonas infection. Okay? So the correct answer here is letter C. Guys, iilan lang ang organisms that can grow at 42 degrees Celsius. So tatandaan nyo na sila. One of them is Pseudomonas. Okay? So, just to show you yung picture ng patient na may cystic fibrosis, di ba? Malagkit na malagkit, ganyan. And that actually is a fertile environment for Pseudomonas to grow. Okay? And to show you yung greenish discharge that I mentioned, di ba? So, yun yung tinatawag nating blue pus. Green pero blue, no? Yun yung term no? Blue pus. Okay? So, even when you cultured it, no, you can have a greenish discoloration, no? That's because of the pigments produced by Pseudomonas. Iba-ibang pigments yun, no? So, you have pyoviridine, pyocyanin, and even pyorubin. Nice to know lang naman. And if you have infection of the eye caused by Pseudomonas, there can also have greenish discoloration. So, ang tanong lang naman sa atin, no? What is the most appropriate drug to give in this patient? So, in short, which one would have pseudomonal coverage? Would benzathine pen-G have pseudomonal coverage? Wala, no? Because, sa mga penicillins natin, no, iilan lang naman dito yung may pseudomonal coverage. And one of them would be yung mga piperacillin, tazobactam, carbenicillin, ticarcillin, ganon. Okay, so si benzathine pen-G, wala siyang pseudomonal coverage. Si cefoxitin, wala din, no? Because cefoxitin is a second generation, second generation cephalosporin. And sa kanila, no, sino ba yung merong pseudomonal coverage doon? It's only cefoperazone and ceftazidime, okay? Sila yung mga third generation cephalosporins natin, diba? Para maalala sino yung mga third gen, diba, yung puro yung mga pera, diba? Cefoperazone, cefotaxime, ceftazidime, okay? So, letter C, ertapenem. All carbapenems would have pseudomonal coverage except ertapenem. So, i-X din natin siya. So, the best answer here will be letter D. Okay? So, the best answer here is ceftazidime, letter D. Number 55, Campylobacter jejuni is one of the most common causes of bacterial gastroenteritis. So, of the following are true except, ito na naman tayo, no? So, we have that except. So, tandaan natin siya. Letter A, unable to grow at 42. Na-mention natin to during the lecture, di ba? We said, there are only few organisms that can grow at 42 degrees Celsius. Tama. You have Pseudomonas aeruginosa. You have Campylobacter jejuni as well. Okay? And then so ito yung mali, no? Kasi this is an except question, double negative, no? Unable to grow, hindi. Kasi it should be able to grow. So that's actually our answer. Let's just go over the other choices briefly. Letter B, microaerophilic. That's correct. No, Campylobacter jejuni is microaerophilic, means to say it can grow in the presence of oxygen, but only in small amounts of oxygen. So roughly around 2 to 10%. Letter C, very common cause of bacterial gastroenteritis. Check. And letter D, they are motile, gram-negative with a gull-wing shape, no, configuration. Number 56, the above infection is associated with which of the following sequela? Alam natin yung GBS, di ba? So, choice letter A, GBS. But wait, wag muna agad mag-shade, no? Kasi you have choice B and C pa. Tingnan natin na mabuti. You have Reiter syndrome, choice letter B, and choice letter C, you have reactive arthritis. Actually, they're the same, di ba? So, they're referring to the same entity. So, this is actually letter D. All of the above. Okay? So, yung Campylobacter can have different sequela. Number 57, you have a 24-year-old patient who recently underwent endoscopy following recurring bouts of epigastric pain that awakens him at night. So this is a very what do you call this? This is a very particular na manifestation, no, of duodenal ulcers, pain that awakens a patient at night, no. The gastric biopsy material was tested in a urea-containing medium which turned positive within 2 hours. So anong organism kaya yon, no? Nang positive agad yung urea, so an organism that has a strong urease activity, that's none other than H. pylori. Okay? So this organism is associated with which of the following conditions? So a lot of our patients, so a little kwento lang. A lot of our patients that we receive in GI, they complain of recurrent epigastric pain. They use a lot of PPIs already. They use a lot of mga antacids, and yet they still have persistent epigastric pain. So some of them, turns out, no, kapag tinest mo yung you do a urease test during endoscopy, turns out meron pala silang H. pylori. No, in the Philippines, actually mataas yung rate ng H. pylori sa atin. Okay, so yun, no, you can also have yourself tested if you have those symptoms. And it doesn't have to be invasive. There are non-invasive ways to check for H. pylori as well. Okay, so back to the question, this organism is associated with which of the following conditions? So you have duodenal ulcers, definitely. And gastric ulcers as well, wala dito. But no, yung H. pylori can also promote cancer formation, both gastric adenocarcinoma and lymphomas. So this is actually letter D, all of the above. So that's also the importance. No? When we do EGD, when we do endoscopy, we want to get a small sample from the gastric mucosa to check for H. pylori. Why? Because kumukha siyang bukol, no? Kumukha siyang cancer. Sometimes all you need to do is just to eradicate the H. pylori infection at mawawala na yung cancer. Okay? So if it's mild lymphoma, you know, the early stages of lymphoma, usually H. pylori eradication is all it takes in order to get rid of the condition. Number 58, following treatment, which of the following may be used to assess treatment success? So you know that this is H. pylori testing, so you can do a urea breath test. So mind you, urea breath test is more for checking response to treatment, okay? More than diagnosing the infection. Okay, so pwede tayo mag-stool antigen test if we want to diagnose the infection, but yung urea breath test, that's more for checking response to treatment. So we do get cases na resistant and might require another regimen. Okay? So sa H. pylori testing natin, it's always a combination of antibiotics. We don't use monotherapy na single agent lang. Number 59, all are true about this patient's condition except, tignan natin isa-isa. Choice letter A, eradication of the organism is needed to prevent recurrent disease. Kasasabi ko lang, definitely. Okay? So you need to kill the organism. That's why often we give a 2-week regimen. Race is an important risk factor. Kung di ka sure, skip muna. Sige, lagyan natin question mark. More common in the lower socioeconomic strata. We just mentioned that it's common in the Philippines. Ano nga ba tayo, di ba? Low socioeconomic strata. So this is check. And lastly, treatment may require a combination of antibiotics. It really does require a combination of antibiotics. Okay, so some of the common combinations that we have, no, yung OCA. Okay, so lagay natin dito omeprazole, clarithromycin, and amoxicillin. Pwede din yung BMT. Madaling maalala to kasi BSMT ako, Bachelor of Science in Medical Technology. So, BMT. So, bismuth, metronidazole, and tetracycline. Meron din tayo yung quadruple therapy, no, yung mga OBMT, and so on. Marami pang iba-ibang regimen ngayon, no? You can also use a levofloxacin-based regimen. So, but basically, the take-home there is it's always a combination of antibiotics, and often we give it for a duration of around 2 weeks. So, the correct answer here is boy. So, race here is not an important risk factor. Actually, sa Harrison's ka, sinasabi dun, no? Low socioeconomic strata, no? Poor educational attainment also. Okay, so yung poor education and low socioeconomic strata, those are the associated factors. Let's go to the next question. You have a 6-year-old girl now brought to the ER for respiratory distress. Her mother tells you she declined vaccination. No? The child is not able to lie down flat and prefers to lean forward with the chin lifted. And on examination, on lateral radiography, there was note of thumb sign. So ano nangyayari dito, guys? If you have thumb sign, this is indicative of inflammation of the epiglottis, right? Yun yung pag nag-intubate ka, yung makikita mo parang leaf-like na nakaganon, no? So yun, no? So that's the thumb sign. So when you do your moonlighting, wala nang residents na tutulong sa inyo, palagi mong makikita yung epiglottis and you don't want it to be the only thing that you see when you do intubation. Kasi diba, what you want to see is the vocal cords below it. Diba? Common mistake yun pag nag-intubate, lalo kung umpisa ka pa lang, no? Pag nakita mo yung epiglottis, akala mo yun na yun, no? You have to visualize the vocal cords. Okay, lagi mong iisipin na, tawag dito, yung epiglottis, pag yun lang nakikita mo, mali yung view natin. Okay, wala lang, those are some of the things na yung mga struggles ko before, no? Kasi as an intern, parang once or twice lang ako nakapag-intubate. So, kapag nagmo-moonlight ka na kasi, di ba, when you're in the real world, talagang there's no one there to help you. Kaya you really need to learn very, very fast. Anyway, going back, you have inflammation of that epiglottis there. You have fever, upper airway obstruction. So, one of the most common causes would be H. influenzae, especially prior to the advent of vaccination. Kaya nga, specifically, sinabi natin dito, no? Her mother tells you that she declined vaccination. Okay? So, that's an important clue. So, especially true ito, no? Sa mga foreign examinations, if some of you plan to do MLE or mga PLAB, no? Mga mag-exam sa Australia, they're very particular with this because these are conditions that you don't really see often in their countries, in their respective countries, unless unvaccinated talaga by choice. Diba? So, often the question would mention that the patient is unvaccinated. Ayan. Okay? So, number 61, isolation of the organism above can be done using which culture media? So, we're now talking about H. influenzae, and we can isolate this using horse blood agar. Wag malilito, merong sheep blood agar, but the better answer here is horse blood. Remember, H. influenzae is maarte, di ba? Very sensitive. It's a fastidious organism. So it's very sensitive to temperature changes, environmental changes. No, it gets easily killed. And when you grow it on culture media, you can use horse blood agar, or another one that you can use is chocolate agar. Okay? So chocolate agar, basically heated blood. Okay? Number 62, a major virulence factor of this case is H. influenzae has a polyribitol phosphate. Okay? So it has a polyribitol phosphate capsule, which is a major virulence factor. There you go. You have Haemophilus influenzae over there. It's a very tiny gram-negative coccobacilli. They're very sensitive to drying and chilling, and they tend to exhibit satellite phenomenon. Okay. Si Haemophilus kasi, clingy na kaibigan to. No? It needs somebody to cling on to. Like in this picture, makita mo, it would satellite around cultures of Staph aureus. Okay, it has special growth requirements, yung X factor, V factor. The X factor is the hemin. No, lagay natin dyan. The X factor is the hemin. The V factor is the NAD. Okay, so yun. These are just nice to know lang naman. And you can see that when you culture Haemophilus influenzae adjacent to Staph aureus, they grow as very, very small colonies. It's very easy to miss them out because they're very small, para lang silang dumi, di ba? Now we go to another organism. This one is Haemophilus ducreyi. Haemophilus ducreyi is the causative agent of soft chancre. Diba? Sa board exam, common question din yung mga sexually transmitted infections, genital ulcers, and very important yung mga key points, no? So, kapag soft chancre, it is very painful. Ano nga uling palatandaan natin? Ducreyi, cry kasi masakit, no? So, soft chancre, painful, Haemophilus ducreyi. This one is your school of fish appearance. This is ducreyi. Sige, pangit ang sulat ko, pero naiintindihan naman natin, di ba? This one is H. influenzae, okay? On the right side. So, si school of fish appearance, you think of Haemophilus ducreyi. This one over here, bakit ko nga pala pinapakita to, no? Kasi, I always look at pictures when I'm studying. Lagi kong iniisip kasi yung overall clinical picture because that's easier for me to remember rather than just memorizing brute force. Okay? Itong picture na to, yung nakaganyan, no? Mukhang nakaganyan na thumb, di ba? That's your epiglottitis. That's the thumb sign. And when you intubate, minention nga kanina, no? That's, there can be inflammation of the epiglottis. That's what you call the omega sign naman. Imagine, no? Talagang baradong-barado yung airway. Di ba? So you really have to put that tube in, otherwise hindi makakahinga yung patient natin. Okay. 63. A urine antigen test is useful in the diagnosis of infection caused by which organism? So, urine antigen test, I know, ang unang pumapasok sa atin ay Legionella pneumophila. Very good kung yun ang naisip mo. Okay, so urine antigen test for Legionella pneumophila. There's also urine antigen test for strep pneumoniae, but it's not as, accepted or as readily available as that for Legionella pneumophila. So, the best answer would still be letter C. Okay. Number 64 tayo. What is the most common route of transmission for Legionella pneumophila among immunocompromised individuals? So, ano kaya ang best answer? Paano ba natin nakukuha ang Legionella pneumophila? It's often associated with air cooling towers, air conditioning units, yung mga cruise ships, diba? Tall buildings. Sa Harrison's nga nakalagay buildings more than 3 stories high, no? Hindi ko gets bakit 3 stories. Anong pinagkaiba kung 4 floors? Sa 2 floors, sa 3 floors, di ba? Pero yun ang sabi sa Harrison's. Anyway, so the answer here is inhalation of aerosols. Okay? So ito yung nakalagay guys ha, sa Jowets natin. Ayoko magkaroon ng confusion. Baka mayroong masipag na bata. Sir, nagbasa ako ng Harrison's. Ang sabi sa Harrison's, the most common route of transmission is no longer exposure to air cooling towers, inhalation of aerosols, but now it's aspiration. That's correct. No? Kung sa IM tinanong at meron sa choice ang aspiration, you put aspiration. But if wala, no, tas inhalation of aerosols yung nasa choice, you answer that pag micro. Okay? Kasi sa Jowets, ito yung sinasabi. Magkaiba sila ni Harrison. So it has to depend on what subject we're dealing with. What other clues do you want to look for kung Legionella pneumophila? It now depends, no? Are we talking about atypical pneumonia or Pontiac fever? Remember, Pontiac fever is a mild self-limiting disease caused also by your Legionella, right? But the typical pneumonia of Legionella pneumophila is associated with a lot of extrapulmonary manifestations. So yun yung mahanapin natin sa choices. Other than the risk factors na nasa cruise ship, may exposure to air cooling towers, ganun. Okay? So usually they're associated with high fever, hyponatremia, diarrhea. Okay, so yun yung mahahanapin natin sa sa question natin. Okay, may mga ganong other factors that it's not as common as with other etiologies of pneumonia. Okay. Next, let's move on to number 65. You have a 40-year-old construction worker admitted for decrease in sensorium. So that's the chief complaint. But on history, meron na daw cough for the last 3 months. Very important yun because that tells you it's chronic, right? There's cough for 3 months. There's weight loss, night sweats. No? So imaging of the chest revealed numerous nodules resembling millet seeds, and lumbar tap revealed elevated protein, decreased glucose, elevated ADA, adenosine deaminase with numerous lymphocytes. Which of the following is not a characteristic of the organism? So guys, nilagay ko na lahat ng characteristics dyan. So dapat alam nyo kung anong pinag-uusapan natin. This is none other than Mycobacterium tuberculosis, right? So in the body fluids, whether it's CSF or pleural fluid, you can get an adenosine deaminase. Okay? And of course, you would see lymphocytosis more than PMNs. And when you check body fluids, it would be unusual to see mesothelial cells. That's something unique about TB, no? Yung mesothelial cells, usually, they don't appear kapag TB siya. Kasi mas dumidikit daw siya dun sa surface, kaya hindi siya nakikita dun sa fluid. Anyway, going back to the question, which is not a characteristic of the organism. Okay, so the organism is a thin, slender, acid-fast, obligate aerobe. Correct. Diba, remember, obligate aerobe ang MTB. In your X-ray, where do you look for TB? Diba? Nasa apices. Titingin ka, ganun-ganun ka, kung plaka yan. No? Because you know that it will go to the area of the higher O2 tension. Contains numerous lipids? Correct. Organism cannot be cultured? Definitely hindi. Kino-culture natin yan. No? We can use Lowenstein-Jensen. We can use Middlebrook. Okay, so it can be cultured in vitro. Okay, virulent strains are known to produce serpentine cord formation. Correct as well. So the answer here is letter C, because ang tanong ay which is not a characteristic of the organism. Alright? So ito yung sinasabi natin na serpentine cord formation. So these are basically individual bacilli na nagdidikit-dikit forming serpentine cord-like formation. Okay? Next question tayo. Pulmonary disease caused by the above infection is indistinguishable from which organism? Okay, so si Mycobacterium tuberculosis, kamukhang-kamukha niya si yellow, no? Bacilli, okay? Si Mycobacterium kansasi, also known as your yellow bacilli. Okay, so si Mycobacterium chelonae, this is actually a rapid grower. Okay? So meron tayong different classification. Meron tayong mga photochromogens, cotochromogen, nice to know. Of clinical significance would be the rapid growers because they are mostly saprophytes. Pampagulo, no? Mabilis sila tumubo eh. So when you're culturing TB, in a matter of few days, tutubo na sila. Okay? So examples ng mga to, no? Mycobacterium flav, vaccae, Fortuitum chelonae, smegmatis, no? So usually saprophytes lang sila. Okay? So aspergillus, they can form aspergilloma in the lungs. Usually nagka-cavitation, sa mga cavitation yan talaga, nagpo-form sila ng fungus ball. Okay? And usually surgical din talaga siya. So si aspergillus, take note, we don't treat all cases of aspergillosis the same way kasi magkaiba ng implication when we're talking about invasive aspergillosis, when we're talking about ABPA, yung bronchopulmonary aspergillosis and a plain aspergilloma, magkakaiba yung treatment dun. Okay? So, going back to this question, kansasi can cause pulmonary disease. That's quite the same as your TB. Number 67 is this patient had HIV. Which of the following drugs may significantly increase the metabolism of antiretrovirals? Very pharma question, no? So in short, which one is a CYP450 inducer? Tama? Diba? Kapag increased metabolism, you want it to induce the CYP450, right? So between the two, dalawa lang naman ang usual na binabanggit sa pharma, right? Either isoniazid or rifampicin, right? So letter I, isoniazid, is an inhibitor. Remember, I is for inhibitor, not increase the metabolism, but inhibitor. Rifampicin is an inducer. So the correct answer here is boy. Okay? So rifampicin. Let's talk a little bit about expert MTB rif, no? So this is now delegated as the primary diagnostic test for both pulmonary and extrapulmonary TB. Okay, so you can also encode for it can also detect a resistance to rifampicin. No? So, pag tinanong kayo, no, which of the following tests for tuberculosis may also detect rifampicin resistance? Oh, obviously, that's expert MTB rif. You can use those samples, and nice to know, I want you to look at the different notations. Baka tanungin lang. Okay? So, baka tanungin tayo, what does a letter T mean? Diba? Like, nakalagay sa result, T. And even in actual practice, no, pag ginamit yung letter T, at least you know. It means to say that TB has been detected. Okay? Pag RR, na-detect yung TB with rifampicin resistance. Okay? Kapag TI, indeterminate. I for indeterminate. N for not detected. And a single letter I for invalid result. Alright? So, just familiarize with those notations kasi who knows? And even in real life naman, magagamit mo siya. Excuse me. So next, let's go to direct sputum smear microscopy. Now this is already, taking a back seat. It's now an alternative diagnostic test in areas where expert MTB rif is not available or accessible. So you need two samples, no? The first sputum is a spot collection. The second one, you can collect it 1 hour later or early morning the next day. It doesn't matter anymore. And you only need one positive test result para masabi mo na positive for TB siya. Unlike noong unang panahon, I remember when I was in college, the recommendation was to get 3. And you need 2 out of 3. So that's long gone already. Okay? Let's move on. Number 68. You have a 30-year-old vagrant with shortening of the toes and fingers, loss of eyebrows. We call it madarosis. Diba? Disfigurement of the nose with painless lumps in the face and earlobes. So what is the most appropriate diagnostic tool for this particular case? So this is a case of leprosy, right? So for leprosy, we can do a simple slit smear microscopy. Okay? So you can visualize those clumps of acid-fast bacilli. That's what we call globi. That's for Mycobacterium leprae. And can we culture Mycobacterium leprae? So unlike Mycobacterium tuberculosis, we cannot culture Mycobacterium leprae using culture media. But we can use tissues, no? Tissue culture. You can use the foot pad of the mice or the armadillo. Okay, so yeah, that's the armadillo. This one. Yung armadillo is actually the reservoir host of your Mycobacterium leprae. Okay. So if you do a lepramin test, what would be the expected result? Now go back to the question. Sabi sa tanong, the patient has already multiple painless lumps in the face, there's disfigurement of the nose, there's loss of the eyebrows, right? So looking at the spectrum, naalala nyo pa ba yung spectrum ng Mycobacterium leprae? Di ba merong tuberculoid, borderline, and lepromatous. And there are, of course, the in-betweens, no? Na hindi naman na ganun ka-specific sa micro. So if lepramin test, remember that lepramin test is an immune-based test. So in order for this to be positive, there has to be some form of immunity left, right? So the cell-mediated immunity should be intact, otherwise it will not turn positive. So sa tuberculoid, positive pa siya. Pagdating sa lepromatous, negative na kasi wala nang immune system, wala nang immune response sa lepromatous. That's why widespread na yung presentation niya. That's why in this patient, may multiple painless lumps on the face, ganun na, disfigurement, and so on. So therefore, in this patient, you expect it to be negative, no? Most likely. If you are to venture a guess, most likely negative na siya. Let's go through some other common mycobacteria. Scrofulaceum, we've mentioned this. You may scrofula, no, the painless, what do you call this? Lymphadenopathies in the neck, no? And MAC or MI, Mycobacterium avium intracellulare complex, MAC or MI, you often see this in the context of HIV patients, especially if the CD4 count falls below 50. Mycobacterium gordonei, call it the topwater bacillus. Marinum for swimming pool granuloma, and Kansasi, the same pulmonary infection as TB. Moving on, you now have, for number 71, a suspected case of Mycoplasma pneumoniae who was empirically treated with coamox. Patient was shifted to Merop, but still no response after 1 week. If this was indeed a case of atypical pneumonia caused by the above organism, then what is the most likely cause for the lack of response? So remember, si Mycoplasma, if you remember the lecture, no, si Mycoplasma, it actually has no cell wall. Remember? In general, all bacteria, they have cell walls, no? But si Mycoplasma does not have cell wall. So if you're giving an antibiotic that targets the cell wall, you're giving beta-lactams eh. Coamox, Merop is still a beta-lactam, right? Even if iisipin mo, ang lakas-lakas ng Merop. Pero hindi yan gagana because it's not a beta-lactam. I mean, there is no target. Correct? Therefore, the correct answer here is the organism lacks the target of the antibiotics. Si choice letter A, the organism has sterols in its cell membrane. Tama naman, meron naman talagang sterol. But it's not the reason for the lack of response. Okay? So minsan, maraming tamang sagot, no? And totoo naman, no? Usually, Mycoplasma may need longer duration of treatment, no? Pero hindi kasi yan yung reason. Okay? Number 72, which is associated with the organism above, isa-isahin natin. Cold agglutinin disease, pwede ba? Yes, definitely. How about paroxysmal nocturnal hemoglobinuria? Hindi. Magkaiba ang PNH sa PCH. Okay? But both sila hindi, no? So it's CAD that is associated. So si cold agglutinin disease, you have IgM antibodies that promote agglutination in the cold, no? That's why when you extract blood samples from these patients, you would notice if you put it in the room, maya-maya, tignan mo yung tube niya, tignan mo ganun, magka-clump yan, magbubuo-buo siya. So what you do is, you put it in a water bath, iinitin mo siya, okay, before you run the sample. Okay, and then it will disperse kapag na-heat na siya. Okay? So, wag kayong matakot kung may nakita kayo nagka-clump after yun mag-extract kayo ng blood. That's indicative of baka may cold agglutinins dun sa sample. You just have to heat the sample before running it. So, 72, you have letter A, cold agglutinin disease. Okay, next. True of the organism above. No, we don't really like these types of questions, but sometimes, it still comes out in the exam. So, better to be used to them. So, isa-isahin natin. For mycoplasma, can this be cultured? Yes or no? So, it can be cultured. So, mali yun, no? Because you have different culture media for that. You have the Eton agar, you have the New York City media also. So, it can be cultured. And it would have actually a fried egg appearance when you culture it. So, number 2, no, do not contain peptidoglycan. Ano ba yung peptidoglycan? Is it a component of the cell wall or is it a component of the cell membrane? Peptidoglycan, di ba, building blocks of the cell wall, di ba? So, therefore, pag wala siyang cell wall, most likely wala siyang peptidoglycan. Correct? So, check. We know that it's associated with Guillain-Barré, and infection results in sudden onset fever, often with productive cough. Hindi, kasi sabi natin, ang mycoplasma more of a typical pneumonia. Right? Okay, pero in real life, no, hindi naman talaga yun ganun. Parang, hindi enough yung clinical presentation to say na atypical, typical. It's not so evident in real life. But for exam purposes, no? So you have 2 and 3. So the best answer here is choice letter B, 2 and 3. Alright? Next, number 74. 21-year-old G2P2 2002 presents with vaginal discharge and lower abdominal pain. And on examination, your patient was febrile and tachycardic. Yung cervix natin is firm, long, and close with cervical motion tenderness. So when you have cervical motion tenderness, no, what does that mean? No, what does that indicate? Saan ba natin siya ginagamit? So have you done this before? Medyo morbid siya. Ayoko na siyang gawin. No? Di ba parang siyang, yung tinatawag nating chandelier, di ba? Chandelier sign, no? Or wiggling tenderness. So basically, you want to hook that cervix and move it side to side, no? Kasi connected yung cervix natin wala naman ako niyan. Di ba connected yung cervix ninyo sa, di ba, sa uterus. Tapos pag minove mo siya, gagalaw siya. So if there's pain, there's infection. So that's indicative of pelvic inflammatory disease. Okay? Anyway, going back, gram stain of the endocervical smear revealed numerous PMNs pero walang bacteria. So what's the most likely cause? Guys, Neisseria gonorrhea, can this cause PID, pelvic inflammatory disease? Definitely check. Pero wala kasing bacteria ang nakita. So if walang bacteria ang nakita among all of these organisms, which one would be the more likely organism implicated? It's none other than your chlamydia. Okay? Si chlamydia nga, tinatawag natin siyang causative agent of silent PID. So pelvic inflammatory disease but not so much discharge as that in Neisseria, okay? Pero it's really hard to definitively differentiate them, diba? Okay, pero yun, no? So silent PID. Number 75, test of choice for the diagnosis above. So kapag chlamydia, hindi naman natin siya pwede i-KOH, diba? Yung KOH para yan sa mga fungi at in the context of vaginosis, for your whiff test, diba? For bacterial vaginosis. Culture, di natin madaling makukulture ang chlamydia. So, X din yan. Electron microscopy, well, pwede mo namang gawin, pero pahirapan mo yung sarili mo. So, the best one is letter C, NAATS. Okay? But in real life, no, you will not be faulted for treating without testing, without doing NAATS. Okay? Kaya nga, di ba, if you have sexually transmitted infection, may urethritis, di ba, paano ba natin ginagamot yung gonorrhea? Ceftriaxone plus doxycycline, because the doxycycline is actually meant for the chlamydia, no, to cover for chlamydia. So kapag usapang chlamydia, may dalawang body tayong tatandaan, the reticulate and the elementary. Paulit-ulit na rin na-mention natin to, no? So si reticulate, metabolically active, replicative form. Elementary is inert, and that's the infective particle. So si serotype A, B, and C can cause trachoma, no? One of the leading causes of blindness. Ito yung gusto kong tandaan, no? Si serovar L1, L2, L3 can cause a sexually transmitted infection, which we call lymphogranuloma venereum. Okay? And a test for this is what you call the Frey test. Okay? Although in real life, wala namang gumagawa niyan, no? Yung Frey test. Okay? And then the other serovars can cause genital tract infections as well. Okay, move on tayo, number 76. You have a kindergarten student presents with a 1-week history of fever and runny nose. This was followed by repetitive coughing episodes that end with an inspiratory whoop. At which stage of the illness is he most likely in? So, nasa giveaway na, may whoop. So, we are talking about whooping cough, right? So, sino ba dito yung may end inspiratory whoop? So, which stage rather? So, ano nga ba ulit yung stage ng tawag dito ng whooping cough. So you have the catarrhal stage, paroxysmal, and the convalescent. Of course, the incubation, that goes without saying. So, in these three stages, no, dun sa catarrhal, paroxysmal, and convalescent, nasan si whoop? During the catarrhal stage, as the name would imply, catarrhal, no, uhugin, no, maraming secretion. That's actually the most infectious stage. Okay? Boy is the most infectious stage. Si paroxysmal, doon tayo nakakarinig nung whoop, no? Kaya nga nasa pangalan na, di ba? Nandun yung mga paroxysmal coughing episodes. Usually, if you have whooping cough, it would have a subacute, no, type of cough. It's prolonged pero hindi pa chronic. Okay? Usually, it's a subacute type of cough. Okay? And the letter D, convalescent stage. So, wala, no? So, it's in letter C. So we have this graph over here, no, showing you during the catarrhal incubation period, definitely you're asymptomatic. Incubating pa nga. Catarrhal stage, uhuhugin, catarrhal no? So secretions, no? And that also corresponds with the infectivity. During the paroxysmal stage, you have the cough with the end inspiratory whoop, lymphocytosis, yung vomiting, no, that usually follows the coughing episodes because during this time, no, sa kakaubo mo, nagkakaroon tuloy ng post-tussive na vomiting. Okay? Usually, it can last for 3 to 8 weeks, no? And then, during the convalescent stage, makikita niyo yung orange na line, bumababa na rin si clinical, di ba? Because during this time, patapos na rin yung coughing episodes na yan. Okay? So, there. Number 77 tayo. You have an African man was suspected of having chlamydial keratoconjunctivitis. Purulent ocular discharge was obtained for examination. Which microscopic finding will most likely confirm your diagnosis? So, Wharton-Finkelday, Councilman Henderson-Patterson, or Halberstadt-Proazek. So, yung chlamydia dito is, letter D, Halberstadt-Proazek. Okay? So, si Rickettsia, it's an obligate intracellular organism. It's an obligate organism similar with chlamydia. Okay? There's a lot of confusion between Rickettsia, chlamydia, and the viruses, but the difference here is that they still, have characteristics of bacteria in the sense that they have both DNA and RNA. Kasi remember, viruses, they can only be DNA viruses or RNA viruses, but never both. Bacteria pa din siya at the end of the day. No? So they multiply by binary fission and they would always have an arthropod vector. Okay? So may nagtatransmit sa kanila. And it would be characterized by a triad of fever, headache, and rash. For board exam purposes, usually may kwento-kwento yan. So, magkakaroon ng setting kung saan ka makakagat ng vector. So, whether camping, nag-outing, ganun. Okay, number 78 tayo. Okay, you have an 18-year-old male coming to your clinic because of maculopapular rashes on the palms and soles. So, pay close attention, no? Rashes on the palms and soles. So, that would narrow down now your differentials, right? On further probing, he claims he had a painless ulcer at the tip of the penis, spontaneously disappearing after 6 weeks. He goes on to tell you he engages in unprotected sex with multiple partners. So what is the most likely organism here in this case? Answer, Treponema pallidum. Okay? So yung clues natin, palms and soles, that tells you this is secondary syphilis already. The ulcer is painless and even without treatment, it goes away. Okay? So yun. There you go. So you have the ulcer at the site of inoculation. Kung nasa genital area man or nasa mouth for whatever reason na napunta siya dyan. But you know guys na it should be at the site of inoculation. So yun. Okay, this one. So palms and soles, and then you have those wart-like lesions in the genitals. So that's what you call condyloma lata. And this one is what you see in tertiary syphilis, disfigurement. And for children, no, yung congenital syphilis, you have the Hutchinson triad, and that is what you call the Hutchinson teeth, diba? Yung cute na batang may ganun. Okay, so parang siyang bat. So number 79, which of the following techniques may be used to visualize the organism during the early stage of the disease? So remember, no, sa ating syphilis, there are different stages, diba? So you have primary, you have secondary, and then you have tertiary syphilis. You would notice actually that this is not so, not being emphasized as much anymore in your textbooks. No, kasi we're slowly really getting rid of those staging because they don't really have definite cut-offs, no? a lot of the times may overlap yan no? So that's why in the question we mentioned early stage, right, rather than saying primary syphilis. Okay, anyhow, so during the early stages, no, so roughly in the primary syphilis, so usually what we, during this time, no, wala pa tayong antibodies, right? So you cannot use serology. So during primary syphilis, often what you do, no, is you want to directly visualize the organism. So one way to do that is through dark field microscopy. Okay, so that is choice letter C. You cannot use gram stain or Giemsa stain. You will not be able to stain the organism. Okay? Number 80, patients suddenly develop neurologic symptoms. So which of the following is the most ideal to confirm your diagnosis of neurosyphilis? So here, remember that we have non-treponemal test and treponemal test. So itong dalawang nauna, RPR and VDRL, these are the non-treponemal. Okay? So hindi sila specific to the antibodies against syphilis. Whereas tong dalawa na nasa baba, no, these are the treponemal tests. So what would be the difference of non-treponemal and treponemal? Si non-treponemal, this would target the reagenic antibodies, no? Yung reagin. Okay, so kaya nga minsan tinatawag din tong reagenic tests, no? So yung non-treponemal. So si non-treponemal, you can use that to actually monitor treatment response. Because the moment that you already treat the infection, it should be negative already. Si FTABs tsaka MHATP, the treponemal test, you cannot use it to monitor treatment response because the antibodies will stay even after treatment. Okay? Even after you successfully treated the infection already. Okay? So, going back no to RPR and VDRL. So, ano yung mga caveats nito? No? Si RPR, this is actually macroscopic. So, you don't need to use a microscope. No? It is macroscopic. And it makes use of charcoal para makita mo siya. Oftentimes, RPR ang ginagamit natin. Okay? So, si VDRL naman, gumagamit tayo ng microscope. No? So, this is microscopic. Yung tinitignan natin dito is yung flocculation. Okay? So, flocculation. Anyway, ang tanong natin dito, no? If you're going to test for neurosyphilis, if you're suspecting neurosyphilis, and then, ang sample natin dito ay CSF, which one would be better? Would it be the non-treponemal or would it be the treponemal? So the answer here is either A or B, the non-treponemal. Why? So bakit non-treponemal? Kasi guys, if you're going to target the antibodies against syphilis, no, and you're using a CSF sample, you're not really sure if it's neurosyphilis or if it's just passively transferred antibodies from the serum going to the CSF. Nakuha yon? So baka kasi passively transferred lang siya, hindi talaga siya tawag dito, indicative of neurosyphilis per se. Okay? So you need to use a non-treponemal test. And between RPR and VDRL, RPR stands for rapid plasma reagin. Sinabi na nga niya plasma yung gamitin mo, wag mo nang ipilit na gumamit ng CSF, right? So you use VDRL for CSF samples. Klaro? So the correct answer here is boy, VDRL. Okay? Next, you have a test result of RPR positive, VDRL positive, FTABs negative. So, ano kaya to, no? RPR and VDRL non-treponemal tests, they are usually delegated as the screening tests. And then confirmatory natin yung FTABs, right? Yung mga treponemal test. But, kung positive sila, nag-negative yung confirmatory, ano kaya yun? Any pwedeng false positive. Okay? So, unfortunately, with VDRL, you can have biological false positive. So different conditions can lead to a false positive test result like lupus, leprosy, RA, RF, drugs, and infections, no? Hepatitis, EBV, and so on. And that's the reason why VDRL, pag nag-positive siya, hindi automatic na syphilis agad. Okay? Lalo-lalo na kung yung FTABs mo negative because if it's really syphilis, the FTABs should be also positive. Okay? So remember this, ha? Pwede rin itanong yan. So, we opted to treat the patient with penicillin G. 24 hours after treatment, developed tachycardia, fever, chills, hypotension, and diaphoresis. Ano kaya yun nangyari? So, the question is already leading us, no? Na sinasabi niya na related to sa paggagamot mo kasi 24 hours after treatment. So, ano kaya yun? It is Letter B, no, the patient is experiencing a Jarisch-Herxheimer reaction. So guys, no, yung Jarisch-Herxheimer reaction is actually not specific for syphilis. It's seen in the other treponemes as well. Okay, so wag niyo isipin na specific siya. So you can also see it in Borrelia, leptospirosis, no, and usually that's a response against the dying treponemes or the dying spirochetes. Okay, so let's try to identify the image. So in the picture here, no, so nakita nyo to and ito, no, so it's beefy red, pulang-pula, no, meaty yung itsura niya, beefy red. And then you have a sample over, you have a microscopic view over here. You have intracellular organisms. This is Calimotobacterium granulomatis, or the new name is Klebsiella granulomatis, or in short, this is Donovanosis. Okay, so mas maganda kasi na may mental image ka para mas ma-differentiate mo sila. This one, dun sa penis dito, napaka-casual, no? Dito sa penis dito. Di ba may mga vesicles doon, no? They are grouped together. Which organism kaya, no, can cause a group of vesicles at the genital area? So you can think of herpes simplex, no? HSV. Vesicular eh. This one, you have a ulcer na mukhang matigas, no? So this could probably be syphilis. Okay, although looking at the ulcer alone, medyo mahirap sabihin kung Ducrey or what do you call this? Primary syphilis, right? The hard chunker of primary syphilis. But either, okay? But usually sa primary syphilis, yung edges niya would be more parang cartilaginous kasing consistency niya. So para talaga siyang mas well-defined yung edges. So yun. So probably this is syphilis. Number 83, a 35-year-old man went camping in the mountains. Several days later, he developed fever with a Tmax of 38.5 accompanied by chills and headache lasting for 5 days. 10 days later, naulit na naman another similar episode of fever. He claims to feel well in between episodes. So what laboratory test will you request for the patient above? So una muna guys, no, ano ba tong condition na to? Naglagnat, nawala, naglagnat na naman. So paulit-ulit, recurrent, no? So you now want to think of conditions or disease entities that would present with recurrent fever. Or para siyang paroxysmal or periodic, no? So it's you need to think of dengue. Not dengue, sorry. You need to think of malaria. Diba? So you have quartan, tertian, malaria, diba? There's periodicity pag pinag-uusapan yung malaria. Babesiosis, what else? Relapsing fever, okay, caused by Borrelia recurrentis. Okay? However, for this question, what would make me think na this is less likely to be malaria? Look at the interval, 10 days later. Meron ba tayong malarial species that would have recurrent fever every 10 days? Wala, right? Quartan, tertian, wala namang tension, no, diba? Pauso. Okay, so this is most likely Borrelia recurrentis infection, relapsing fever. And in contrast to the other spirochetes, si Borrelia recurrentis kasi guys, no, pwede natin siya makita under the microscope even without special staining, dark field microscopy, simple GIMSA stain, you can already see Borrelia. Okay? Yun yung difference, ha? The rest, si treponema, lepto, usually ano yan no? Dark field. So the correct answer here is letter C, peripheral blood smear. So look, you have those spirochetes there in your peripheral blood smear. They can be stained using GIMSA. Number 84, which is true of the above case. So letter A, repeated febrile episodes are associated with reinfection. Unlikely, no? Bakit ganun? Every 10 days, every 7 days, mag-fever. Parang unlikely naman na ma-reinfect ka na ma-reinfect, correct? Febrile episodes coincide with lysis of RBC and release of parasitoids. This is in the context of Plasmodium. And we are not talking about Plasmodium. Each relapse is associated with an antigenically distinct variant. Correct. Okay? So, it's basically just fooling your body into thinking it's a new infection because it will change its antigenicity. But in reality, it's the same infection. Okay? So, walang bago infection. It's just the same infection. It's just trying to look like a new person. Diba? Parang tayo ting Pasko. Sabihin natin, starting this year, magbabago na ako. Pero day 2, ayun na naman tayo. Letter D, relapses are associated with the presence of hypnozoids. So this is in the context again of malaria. Okay? So hindi yan for Borrelia. Okay. So that's it for the bacteria. So now let's talk about the fungi naman, no? And then the viruses and the parasites. Okay, 85. Dimorphic fungi are best characterized as, ano bang ibig sabihin pag dimorphic? Dimorphic, dalawang form. So it has to depend on the temperature. Okay, whether we're talking about room temperature or we're talking about body temperature. So kapag room temperature, ano ba yung nasa kwarto natin? Amag, mold, di ba? So at room temperature, they are in the mold phase. At body temperature, they are in the yeast phase. Okay, so not all fungi would have this ability. Okay, so it's letter A, fungi that can have a mold phase and a yeast phase. So nagpakahirap pa ako magsulat, no? Nandito naman pala sa slides ko yun, di ba? So, yeast phase or mold phase, okay? So, you need to be familiar with the organisms that are dimorphic, no? Kasi pwedeng tanongin yun. Pero an easy way to remember it, basically all of the endemic mycosis, all of the agents of systemic mycosis are dimorphic. Because otherwise, how can they infect you? Diba? So that would also facilitate the way they infect you because they can exist in the environment in the mold phase, infect you, and then it can become the yeast phase inside your body. Correct? But there is one thing that's quite off here, no? Si Sporotrix schenki. Because Sporotrix schenki, if you remember your lecture, it's not an endemic mycosis. It's actually a subcutaneous mycosis, right? Pero tandaan, it's still dimorphic. Yung mga penicillium, hindi sila lahat dimorphic, but specifically Penicillium marnifae, thermally dimorphic. Okay? A little bit about the fungi, they can be hyaline, no? Clear sila, non-pigmented. They can be pigmented or phaeoid. Another term for phaeoid is demaciaceous. Okay, so they are darkly pigmented because of the melanin. Number 86, no? Punta tayo dito sa question sa mycology. You have a 24-year-old male who sought consult because of circular bald patches with short hair stubs. Sinabi na niya, you're considering black dot tinea capitis. So which of the following tests should you perform? Answer? Alam ko marami magsasagot ng Wood's lamp. Okay, but the correct answer here is letter C, microscopic examination with KOH. Bakit ganon? Okay, because we are specific, no? Sinabi na sa tanong, the consideration is black dot tinea capitis. And there are two types of tinea capitis. You have the black dot and you have the gray patch tinea capitis. So si black dot tinea capitis really goes inside the hair follicles. So if you do a simple Wood's lamp, it might not be positive. Kasi nasa loob siya ng hair follicles. But if we're dealing with gray patch tinea capitis, no? So definitely if you do a Wood's lamp, it will light up. Okay? So that's the difference. So choice letter C is the correct answer. 87, the most likely cause of this patient's condition is black dot tinea capitis. You think of Trichophyton tonsurans. Okay? So let's review quickly. Tinea barbae for infection in the beard and the mustache. Tinea capitis in the scalp. No? So sinabi na natin what are the two types. You have black dot and gray patch tinea capitis. Black dot is an endotox infection caused by Trichophyton species. Ectotox infection, you have Microsporidium. Okay? So, tinea favosa, it's a specific type. This would lead to tissue scarring and it's caused by your Trichophyton schonleini. This one is quite unique. You have the cup-shaped flakes called scutula. No? Paki-add yung word na scutula. Nawala. No? So, cup-shaped flakes called scutula are formed. And the infection is at the base of the hair follicle. So, it can really cause hair loss. Tinea cruris in the groin. You call it the jock itch. Tinea corporis in the body, tinea manum hands, manum, di ba? Manual labor using the hands. Tinea pedis, no? So you have the athlete's foot. And then tinea imbricata. So tinea imbricata is not really, strictly speaking, shouldn't be part of this categorization because it's a distinct lesion. It involves a portion of the trunk and you will have those concentric rings of scaling tissue. So bilog, 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 yung parang cheese. And that's caused by your Trichophyton concentricum. Okay, so sometimes it can be mistaken for other dermatologic conditions when you're working in the community, especially for those with poor hygiene, close contact, no, sama-sama sa isang lugar. So usually that's where you see it, and turns out it's just a fungal infection, and you would think it's something already that's rare and something unusual, but it's just a fungal infection. Okay, this is your Wood's lamp. This one, ano kaya yan? Merong scarring, there's hair loss, and there are those cup-shaped lesions called scutula. Ano nga uli ito? Trichophyton schonleini. Okay, or favus. Another picture of favus. This one, infection in the body, you have your Trichophyton corporis. Kapag nasa singit, pag nasa groin, it's your cruris, no? The causative agent of jock itch. Ito yung sinasabi kong imbricata, okay? So, it's caused by your Trichophyton concentricum. It goes around in concentric circles and sometimes madami yan, no? So sometimes it can be confusing. You would think, baka ano to, other weird dermatologic condition, but it's just fungi. Okay? So it pays to do a simple, ano nga pwedeng gawing test dito? You can do a simple scraping and then you can do KOH. Okay? Para saan yung KOH? The potassium hydroxide will dissolve the keratin. Okay, the keratin in the screen, in the debris, the keratin debris, so that you will be left with the fungus. So when you look at it under the microscope, you can see those hyphal elements. Okay, that's a simple maneuver that you can do. If this were to be Trichophyton mentagrophytes, what would differentiate it from Trichophyton rubrum? This is a common question, no? So sa fungi, we seldom think of biochemical tests, no? So a common scenario would be to differentiate mentagrophytes and rubrum. So in this case, mentagrophytes would be the one that's more positive, no? Si rubrum yung mas negative, negative, negative. So it's a positive urease test. Punta tayo dito sa table. Trichophyton mentagrophytes, when you do a hair perforation test, papasok siya within the hair follicle. So example, you have the hair follicle over here. When you incubate it, no, with a solution containing trichophyton mentagrophytes, it would go inside the hair shaft. You would see under the microscope, papasok siya ng ganyan. So pwede mong silipin, makikita mo siya. Urease positive, no? See Trichophyton mentagrophytes, and both tests are negative for Trichophyton rubrum. Okay? So, another thing for Trichophyton mentagrophytes, may dyan, no? So, you have the description na spiral hyphae. Okay? So, iilan lang yung organisms na common na na-encounter that would have a spiral hyphae. So, you think of Trichophyton mentagrophytes. Okay? Red pigmentation for Trichophyton rubrum. Ito pala yung sinasabi ko, no? So, for Trichophyton mentagrophytes, I said that it would penetrate the hair shaft, no, when you incubate it. So, positive hair perforation test. So, let's go to number 89. You have a 35-year-old male with leukemia. So, this is probably important kasi baka may yung risk factor niya, no? And then you have bloody nasal exudates with orbital cellulitis. And there is direct examination of the nasal tissues, which reveals broad ribbon-like hyphae with irregular branching and absence of septations. So what is the most likely organism responsible for this patient's condition? So pag nabasa nyo, no, yung irregular branching and the absence of septations, that's already a giveaway. Okay? Because the absence of septations already limits your choices. Okay? In mycology, there are only very few organisms that are aseptate, or those without septations. And they are members of the Zygomycetes. They are your Rhizopus, Mucor, Absidia, Caninghamella, and so on. Okay? So they should be under the Zygomycetes. And in your choices here, it's only Mucor that's under that. So that's our answer. Okay? Pero what if hindi niya sinabi na aseptate? Going back to the question, what would point towards mucormycosis in this case? Number one, the predisposing factor of leukemia. Okay, so yung mucormycosis is really common in the group of patients that are really immunocompromised. Example, leukemic patients, cancer patients, transplant patients. Okay, so yung mga nag-immunosuppressive drugs, autoimmune conditions that they are taking steroids, no? Pwede rin yun. Okay, and usually the site of predisposition would be orbitonasal. Okay, so pwede rin brain, no? So there can be neurologic manifestations as well. Okay, so the key difference, no, sa aspergillosis and mucormycosis in terms of the branching is that in aspergillosis, it's an acute angle branching, right? Maliit yung angle. Whereas for mucormycosis, this is often described as a right angle branching. Okay, so right angle branching or a 90-degree branching. Okay? But dito bakit sinabi irregular branching? Okay? Because in real life, no, you don't always see those right angle branches. Why? Because those right angle branches, no, they can easily get folded, no, during specimen processing, and they can appear like irregular branching. All right? So yun yung reason. So letter D, mucor. Number 90, which of the following is true for Candida albicans pseudohyphae formation? Check, no, that's correct. You know that Candida, no, this is a yeast, no, it does not have a mold phase. But Candida can form pseudohyphae. It's not a true hyphae, it's a pseudohyphae. It only looks like a hyphae, but it's not a real hyphae. So how does it look like a pseudo hyphae? So example, you have your yeast cell over here. It will form a bud. That bud will form another bud, and another bud, and bud, and bud, and bud, and bud. So under the microscope, pahaba na sila, mukha na silang pseudo hyphae. Okay? Can also produce large spherical chlamydospores, and they can only form true hyphae after incubation in serum, and that is what you call a germ tube. Okay? So mula dito, no, example, that's the yeast, no? When you incubate them in serum, no, they can form a germ tube that looks like that. No, ang pangit, no? Pero naintindihan nyo naman. Di ba yun ang mahalaga? Okay, so letter C, formation of a true hyphae after incubation in serum. That's also true. So therefore, we have letter D, all of the above. Okay? Next, number 91. You have a 45-year-old male from Ohio with cough and low-grade fever. Nag-spelunking daw, no? So that's a clue. Chest x-ray revealed hilar lymphadenopathy with pulmonary nodules, and TB workup came back negative. So it looks like TB on chest x-ray, but it's negative, no? TB workup came back negative. You're now entertaining systemic mycosis. Sinabi na natin, if this were to be histoplasmosis, what would be the expected finding? Okay, guys, no? So, another generalization. Agents of endemic mycosis and systemic mycosis, all of them are transmitted via inhalation. So, the lungs are the usual portal of entry. Okay? That's usually the case. And they usually have manifestations that's quite similar with TB. So, you need to differentiate it from TB. So, paano natin ma-differentiate yung one endemic mycosis from another? Number one, geographical distribution. Sinabi na niya, Ohio. Okay? And then the route, no? So, sabi, spelunking. So, spelunking, cave exploration, pwedeng ma-expose sa mga bats. Okay? So, yun yung iisipin din natin, no? Meron siyang exposure sa bats. So, therefore, this is a case of histoplasmosis. And histoplasmosis, ano yung characteristic finding? Oval yeast cells within macrophages. Okay? That is the yeast phase of histoplasmosis. The mold phase of histoplasmosis would be characterized by the presence of the tuberculate macroconidia. Remember that? Okay, so sino si multipolar budding? This is your paracoccidioides. How about yung may large spherules containing endospores? This is your coccidioides mycosis. No? Coccidioides immitis. Okay? Thick-walled oval yeast cells with broad-based budding. That's your blastomyces dermatitis. Next question. 92. You have a 10-year-old male with multiple nodules on the arm, developing after he sustained an injury while playing outdoors. Nodules progress to involve the entire upper arm. So, on examination, you have cigar-shaped yeast cells. So, ano pa yung consistent with the organism above? So, first of all, what infectious agent are we talking about? So, this is your sporotrichosis, no? Sporotrich schenki. And another finding would be the presence of your asteroid bodies. Okay, so that's letter B. So sporotrichosis is a little difficult to treat. You might need IV antibiotics like itraconazole. And tingnan natin, no? So para maalala niyo yung description kanina sa question, kasi ang hirap tandaan, no, kung dinedescribe lang na nodules developing along the lymphatic drainage. In real life, ano yun, di ba? But when you look at this picture, you can see, dito natusok siya. That's the portal of entry. And then along the draining lymphatics, nagkaroon ako ng mga nodules. Okay, so this is very, very typical of sporotrichosis. You need to remember that. Okay? Ano naman tong mukhang bulaklak na nandito, no? So this is your asteroid body. Okay, that's also something that you will see for sporotrichosis. Number 93, you have a 45-year-old male who came to the clinic with a 10-year history of multiple firm nodules over the right foot. Very important, 10 taon na daw. Okay? So that tells you that this is a chronic condition, probably not so fatal naman, kasi ang tagal no? He often walks barefoot, no? When working in the garden. Examination, you see draining sinuses. So what is the most likely diagnosis? So the answer here is mycetoma. Okay? So madura foot. So you have a chronic subcutaneous infection induced by traumatic inoculation. That's why you have the predisposing factor there. No, barefoot daw siya. So you might accidentally step on something, no, and you can have inoculation in the subcutaneous tissues of the fungi. Okay. Ano mga keyword na hahanapin natin dyan? Yung mga granules, draining sinuses with granules. So there are two forms of mycetoma. There's one that's caused by bacteria. There's one that's caused by fungi. So that's what you call the actinomycetoma. no, that's caused by bacteria. The eumycetoma, U means totoo, true, diba? So this one is caused by fungi. So the eumycetoma would be caused by the following fungi. No, one of the more common ones would be Pseudoliscaria boydii. For the actinomycetoma, they are the fungus-like bacteria. They are filamentous, no? So Nocardia, Streptomyces, and so on. Next, number 94. You have a 24-year-old male, known case of HIV, now with sudden onset headache, neck stiffness, and disorientation. You did a lumbar tap, elevated pressures, protein is high, no? Glucose is low. You call this hypoglycorrhea with elevated white count. On India ink, there were clear halos against a dark background. Alam na natin ano to. This is cryptococcosis, no? Cryptococcus. Ngayon, paano ba natin na-transmit ang cryptococcus? This is through inhalation of pigeon droppings. Okay, so this is letter C. Endogenous yeast infection, more of candida, no? Inhalation of bat guano, that's more for histoplasma. Traumatic implantation, more for the agents of subcutaneous mycosis. Quiz, ano to? You have a large oval structure there with multiple yeast cells inside. Ano kaya yun? Parang oval structures inside, you call it a spherule. No? So you see this in coccidioides. This one, may macrophage or monocyte, no, with multiple yeast cells also inside. This is Histoplasma capsulatum. Okay, so histoplasma is not really encapsulated, diba? You know it's a misnomer kasi they're usually intracellular, so it appears as if they are capsulated but they're not. Okay, this one would have tuberculate macroconidia. This is your histoplasma capsulatum mold phase naman. How about this one? So you have one large yeast cell over here and there are multipolar buds, resembling a mariner's wheel. So this is Paracoccidioides. So sometimes mukha siyang Mickey Mouse cat. That's the description in the books, no? So pwede rin yun. How about this one? You have oval yeast cells on a black background, no? So you know this is a negative form of staining, indirect staining. So this is your India ink preparation. So this is for cryptococcosis. So we have a table there in your handout. So I just want you to go over them para ma-review lang ninyo. Okay. So now let's go to the viruses. Number 95 tayo, which viral infection is most associated with aplastic anemia. The infection can also present as a rash with a slapped cheek appearance. So this is your parvovirus B19, okay? So with the characteristic slapped cheek appearance, no, and then under the microscope, it would have a predisposition to infect the pronormoblasts. It can cause a pure red cell aplasia that's transient. It can cause aplastic anemia as well, okay? So that's one of the possible differentials as well. If you have a patient with presenting with aplastic anemia, you don't know already kung ano yung etiology, rather young, na walang other predisposing factor, malignancy is ruled out, no? Number 96, all of the following are diseases caused by paramyxovirus except, so sino-sino ba yung mga paramyxoviridae? So measles would be one notorious member. Measles, mumps, not rubella, that's togaviridae. So respiratory syncytial virus is also a member. So sino yung hindi member? This one, okay? Because ang member ng paramyxoviridae is not influenza but para-influenza, okay? So I don't really require, quote-unquote, no, you to memorize all of the classifications, the families, the members, no, but it would be useful to be familiar with the more common ones like this one, because sometimes the question can be very simple or you can already eliminate a lot of choices based on the groupings alone, diba? So measles, mumps, respiratory syncytial virus, and para-influenza. Okay? So that's not letter C. Paki-correct na lang in your handouts, ha? So all of them are diseases caused by paramyxovirus except letter D, influenza. It should be para-influenza. So si measles, si mumps, and respiratory syncytial virus are all part of it. Number 97, you have a 25-year-old male intern came to you for sores around the mouth and lips. On inspection, you noted groups of vesicular lesions on an erythematous space. So what would be a cheap, rapid, but non-specific test used in the presumptive diagnosis of this case? So the answer here is your chunk smear. No? Yung slit smear, di ba saan natin yun na-encounter? Sa leprosy, di ba? So chunk smear, what do? you remove the roof, no, of the vesicle, no, and then you want to scrape the base, and then you can stain it and you can look at it under the microscope. And since this is mainly for herpes viruses, you'd be able to see those multinucleated giant cells. Okay? Kasi ang herpes in general, di ba, they form syncytia formation or multinucleated giant cells. Number 98, which of the following is responsible for facilitating the release of influenza? Release, tandaan nyo na, pag neuraminidase, release. Hemagglutinin, entry. Pilit na pilit, pero kaya nyo yan para maalala natin. Hemagglutinin, entry, neuraminidase, release. Okay? Number 99. All of the following correctly describes the antigenicity of the virus above except. So we're still talking about influenza. So isa-isahin natin, no? So the virus above, no, is influenza, but you know that there are 3 types of influenza: influenza A, influenza B, and influenza C. Okay? So this is an incomplete question, no. I-qualify natin, no. So let's talk about influenza A. Paki-add sa handouts ninyo. We're talking about influenza A. So influenza A would be capable of both antigenic shift and drift, definitely. Okay? So, antigenic shift, no, would result from genetic reassortment. Tama ba yun? Sino ba yung mas major change? Is it a shift or a drift? Remember, it's a shift, no? Kasi kapag shift, it can lead to pandemics. Ang drift, minor point mutation lang. Okay? So, B is also correct. Influenza A is not capable of causing pandemics. Kakasabi lang natin, it can cause pandemics. Therefore, it's an exempt question. It's our correct answer. Letter D, oseltamivir is effective? Yes, no? Ako personally, I'm a fan of oseltamivir. As you can see, meron akong flu ngayon, no? Tapos sabi ko, I cannot have a flu because I'm in training, no? I'm a fellow. So, kapag you're in training, you have to be, at your best all the time, diba? You cannot, you cannot afford to be sick. So, I'm taking oseltamivir, Tamiflu, no? So, it's quite effective for me. That's my personal opinion. Okay, anyway, but what can be asked in the exam regarding oseltamivir is that it has to be taken within a specific duration. Otherwise, it would not have any benefit. And that magic number there is 48 hours. Okay? So from 48 hours from onset of the disease, you need to be able to take oseltamivir. Otherwise, might as well not take it. Okay? So, si orthomyxoviridae or influenza, they are segmented, and we have an acronym for those viruses with a segmented genome. So, BOR is the acronym, BOR. B for Bunya viruses, O for orthomyxoviruses, A for Arena, R for reoviruses. So, the segmented structure of the influenza would actually facilitate the reassortment of the gene. And that's the reason why every year, you have a new influenza strain. Nanto, meron ako, diba? So, that's why every year, you need a new influenza shot. Okay, napag-usapan na natin to. Mas major, antigenic shift, minor point mutation, antigenic drift. Question number 100. You have a 5-year-old unvaccinated girl who develops fever and malaise followed by appearance of rashes on the trunk, face, and limbs. There were papules, vesicular lesions described as dewdrop on rose petal. This asynchronous development of lesion is most typically seen in... So, I believe we mentioned this a couple of times already. So, what's the answer? C. Varicella. Okay? Your keyword there, no, is the asynchronous development. Other than, of course, mentioning dewdrop on rose petal, no, vesicular lesion. That's varicella. But asynchronous development, di ba yung sabi ko, yung merong bagong lesion, may luma, may pagaling na, may crusted na, may new. So, they're all appearing at different timelines. Whereas for other viral infections, they typically go in one sweep. No? They all appear together, they dry up, they disappear. That's it. No? So for varicella, it's different. It's asynchronous. Okay, nasabi na natin to yung distribution ng rash ng chickenpox and smallpox. Number 101. Which of the following is not a member of Picornaviridae? Okay, so may acronym yan, no? PERCH. So polio is a member, Coxsackie is, Hep A as well. So our answer is smallpox because smallpox is a DNA virus, remember? So it's under your Poxviridae. So hindi siya Picorna. Picorna is RNA. Number 102, Ebola and Marburg, they are filamentous viruses and they belong to which family? So they are under the Filoviridae. Okay? 103, rabies virus. What family do they belong to? So alam ko, you would answer rhabdo, but that's wrong. Okay? Sorry. The question is family, so that's correct. Okay? So rhabdovirus. Okay? What I meant to say was, if the question is genus, no? What genus do they belong to? This is the point of confusion that I want to clarify. Na-confused din ako, no? Lisaviridae is the genus. Okay? So pag tinanong tayo, rabies virus belongs to which genus? You answer Lisaviridae. But if the question is about family, rhabdo ang sagot. Okay? Number 104 tayo, another patient with HIV who refuses to be treated. Several months later, difficulty of breathing na siya, no? Na-admit. Hypoxic, X-ray shows bilateral interstitial fluffy infiltrates. So if you have a patient with HIV who's hypoxic, dyspneic, with bilateral interstitial infiltrates, what organism are you thinking of? So this is, of course, Pneumocystis carinii, di ba? PCP. Okay? Or Pneumocystis jirovecii, that's a new name already. Okay? Examination of BAL, or the bronchoalveolar lavage, revealed presence of cysts. So that confirms your diagnosis. This is PCP. Okay? So what can be inferred from this patient's clinical presentation? So the answer here is the CD4 count is already very low. It's below 200. Okay? So increased CD4-CD8 ratio. Tawag dito. Remember that in HIV, no, we would be there would be a what we call this? You have lower cytotoxic, CD helper, CD4 cells, right? So the CD4-CD8 ratio is actually decreased. Okay? Absolute indication for prophylaxis against wrong, because Mycobacterium avium requires a lower CD4 count, and that's less than 50. And medication is definitely required. And when you're asked, no, how can we prevent getting this infection? We need to give, among other agents, you need to give cotrimoxazole. Okay? Si Cotride, that's just among the many choices that you can give. It's the preferred drug to prevent PCP in patients who already have CD4 count below 200. Okay? So in a patient with HIV-1 infection, what is the most predictive of the patient's prognosis? So ito maraming nalilito, no? When we're talking about susceptibility to infection, short-term outcomes, no? You're more concerned about the CD4 count. But pag prognosis talaga, long-term ang iniisip natin, no? You think of the HIV-1 levels. Okay? So, klaro yun, ha? So, ito kasi prognosis yung pinag-uusapan. Pero pag quantify niya na short-term lang, susceptibility to the disease, no? So, it's more of the CD4 count. 107, most common neurologic syndrome seen as a late manifestation of AIDS is characterized by all of the following except. So, this one, no? It's not something that we commonly encounter, no? So, usually, kapag neurologic manifestation ng AIDS, usually still related with infectious diseases, right? But this one, what do you call this? This one, yung sinasabi dito is regardless of the infection, no? Yung AIDS talaga mismo. Part of the AIDS dementia complex, no? That's the late manifestation of AIDS. So you can have poor memory, inability to concentrate, and behavioral changes. And you can also have psychomotor retardation. So seizures are not part of AIDS dementia complex. Okay? So do remember that seizures are not part of the late manifestation of AIDS. So more of cognitive siya, no? Memory, concentration, behavior, psychomotor, no? So 108 tayo. Number 108, children who are born with HIV infection appears to be at risk for psychiatric disorders by the time they reach their adolescent years. So what would be the most common psychiatric condition in this group of patients? So you have major depressive disorder, anxiety, suicidal ideations, or schizophrenia. So itong type ng question na to, no, it's hard to answer if you weren't able to read it, but it's there in your jawets. Sinabi doon, very clear, it's your B, anxiety disorders. Okay? A lot of people would mistake schizophrenia as the correct answer, but no, it's not. Go back to your jawets. It's actually letter B, anxiety disorders. Okay? Next, number 109. You have a 5-year-old boy presenting with a 3-day history of fever, headache, and joint pains with retroorbital pain. So the general physician is highly considering dengue. So the question is, which of the following tests provides the most reliable evidence of active dengue infection? So what would be your answer? Try to answer nga on your own. So the correct answer here is letter C, analysis of paired acute and convalescent sera. So this is again one of those questions that's difficult to answer if you haven't read it in Jawets, but it's also there. No? You might be tempted to answer NS1 or high titers of IgM, but yun ang sabi. No? It's acute and convalescent sera. Okay? So verbatim yan in Jawets. So here we have a table, no, showing you the different organisms and their characteristic inclusion bodies. Nice to be familiar with. Might be able to help you during the examination. Okay, so let's go over them together. So for herpes, you can have the Cowdry type A inclusion bodies. Yellow fever, you can have the Torres bodies. HPV, not really an inclusion, but the cells, no, you have those large clear cytoplasms, no, so coilocytes. Molluscum bodies, or what you also call the Henderson-Patterson bodies for Molluscum contagiosum. See smallpox, although we don't see it anymore, you call it the Guarnieri bodies. For rabies, you have, ito of course, alam natin to lahat, the Negri bodies. Sa measles, you have your Warthin-Finkelday. And lastly, for cytomegalo, you have the Owl's-Eye inclusions. Okay? 110. Okay, so the HTLV virus, no, yung T-cell lymphotrophic virus natin would be associated with all of the following conditions except, so yung HAM, myelopathy, tropical spastic paraparesis, and lymphoma, adult T-cell lymphoma, all of them. Okay? So lahat sila associated with HTLV, so that's letter D. Next. 111. You have a 50-year-old male complaining of fever, fatigue, and vague right upper quadrant pain. So now move on na tayo sa para, no? A hepatic abscess was suspected, no, on ultrasound, and you aspirated it and you were able to get the anchovy paste aspirate. So what is true of the above condition? So sa mga organisms natin in parasitology, which one typically causes hepatic abscesses? It's your Entamoeba histolytica, right? So, tingnan natin, no? So, which of these features would point towards Entamoeba histolytica? Choice letter A. The patient was able to acquire the infection through ingestion of trophozoites. Mali na agad, no? Although it's correct, remember this, no? Pag Entamoeba histolytica, the way to differentiate it from the other Entamoeba, the other, what do you call this, commensals, no? Na amoeba, would be the ability to ingest RBCs. But you do not ingest the trophozoites. The trophozoites are very fragile, diba? Outside of the body, they immediately encyst. Okay? So it should be ingestion of cysts, no? The quadrinucleated cyst. What is the most common extraintestinal site? It should be the liver, no? So mali din ito, no? It should be the liver. This one should be the cyst. Letter C, a granulomatous tumor-like mass, no, may form on the intestinal wall which may cause obstruction. This is actually correct, no? So this is our answer. And lastly, the most common type of infection is amoebic colitis. That's wrong. Although it's easy to think that it is, no? Pero it's a trick question. The most common type of infection is actually asymptomatic, no? So letter C is our correct answer. Next, how do we differentiate Entamoeba histolytica from the non-pathogenic Entamoeba dispar, no? So all of the following methods can be used except, so they are very difficult to differentiate based on morphology alone, no? So they look exactly the same, okay? So stool analysis, zymodyne analysis, PCR, or ELISA. The question is an except question. So if you're going to use your common sense dito, if you don't know the answer, you're gonna think of something molecular as the basis, right? Kasi mahirap sila differentiate on morphology alone. So stool analysis will be the least helpful, no? If you do a simple fecalysis, magkamukha nga sila. So we won't be able to differentiate them. Okay? 113. How do we culture Entamoeba histolytica? So although it's not commonly done, no? So we can use the NNN, no? The Novi-McNeil-Nicole medium. Okay, so that's letter B. Yung diamond medium, that's for trichomonas. Cled medium, it's your cysteine lactose electrolyte deficient agar. This is for microbes, no? In particular, urine samples. Okay, so urinary microbes. And I mentioned diamond's medium is for trichomonas. Although for parasites nga, as I said, we don't often culture the organisms. 114, You have a 10-year-old male with sudden onset seizures. MRI shows numerous cysts in the subarachnoid space as well as in the parenchymal cyst in the gray-white matter junction. So you're thinking of neurocysticercosis. So what should be the treatment of choice? Cysticercosis. So ano to? Cestodes, di ba? Lahat naman ng cestodes, pati mga trematodes, iisa lang ang gamot. So anong correct answer? It's actually letter C. The best answer here is albendazole. Bakit ganon? Drinik ko kayo, di ba? Praziquantel would be the, the common mistake. But for neurocysticercosis in particular, we are dealing with the larva, no? Not really the adult not really the adult cestode. Because, yung Taenia solium naman, Taenia saginata, di ba? Nasa bituka naman yun. But it's the larva na laquachero travel, right? And to better kill the larva, you need to have a larvicidal agent and you have your albendazole. Okay? 115, you have a 12-year-old boy who develops abdominal cramping and diarrhea with rotten egg odor. So, tandaan mo yan, may sulfide, may rotten egg odor. Direct fecal smear was done which showed trophozoites with floating leaf-like motility. Okay, so anong organism yung pinag-uusapan? Kung merong floating leaf-like motility, ganun-ganun siya, this is none other than Giardia lamblia. Okay, Giardia duodenalis or Giardia lamblia. So the site of existation is in the duodenum. So that's letter B. Okay? So pag sinabi nating existation, no? Ito yung point in which the cyst will become the trophozoite. Balik rin natin, 116. The above organism now will encysst in which site? Saan naman siya magiging cyst, no? From being a trophozoite. So the answer is letter D, it's in the colon. Okay? So you have your string test there, the entero test. So basically, you take in a capsule, you tape the end of the string, and then you will ingest it, it will go down, and you will pull it out again. And then the secretions there, you will examine it under the microscope. Okay? So you can see here yung mga giardia, no? So they can cause flattening of the villi. That's why you can have steatorrhea. Okay? So yun siya. Number 117 tayo. Babesiosis may present with high fever, hemolytic anemia, hemoglobinuria, and jaundice. No? And this can be mistaken for falciparum, but how do we differentiate them? So choice letter A, isa-isay natin. Fever and babesiosis never recurs. It can also recur. That's why it can be mistaken for plasmodium infections. Splenectomized patients are rendered immune? No, they are actually rendered very susceptible, no? So these patients, they can have fatal infection with babesiosis if they are splenectomized. Letter C, the absence of pigment in the red cells and gametocytes favor the diagnosis of babesia over plasmodium. Correct. Okay? So pag nakakita ka ng mga gametocytes, no, especially kung falsi yung pinag-uusapan, these are the banana-shaped gametocytes, that's definitely more of plasmodium falciparum. Okay? Sino ang may Maltese cross formation? It's not falciparum, it's your babesia. Okay? So, si babesia yung may Maltese cross formation. So, letter C is the correct answer. 118. You have a farmer from Leyte, presents with hematemesis. Initial assessment was bleeding esophageal varices. So, basically, if the organism tested, if the patient tested positive for Manzoni infection, the organism will most likely be found in which site? So, in short, what is the habitat, no, of your Schistosoma manzoni? So the best answer here is the inferior mesenteric veins. Okay? So most references would just say mesenteric veins, but it was stated very specific in Jowett that for Manzoni, it's in the inferior mesenteric veins. Okay, so letter B would be the best answer. Schistosoma manzoni, you would have a large lateral spine over there. Japonicum, nasan to? Lateral also, no? But you need to look for qualifiers. Because for Japonicum, it's already very small. It's inconspicuous, no? So those are the descriptions. Knob-like protrusion. 119. Eosinophils may accumulate in the lungs in response to Ascaris infection. So which form of the parasite may be found in the lungs? I always mention this, di ba? The adult stays where they should stay. Okay? Parang totoong buhay, di ba? Yung mga parents natin, nasa bahay, no? Yung mga anak, ng mga lakotsero, sila yung mga pagala-gala, no? So yung lung migration is usually because of the larva. So it's letter B. So the Loeffler syndrome is actually because of the larva. It's not because of the adults. Okay? But of course, Sometimes no, the Ascaris adult can also migrate, no, especially if they are disturbed, no, when you're taking in medications or if you have infections, tapos nataas yung fever natin, di ba? Sometimes intubated patients, pag nilalagnat sobrang taas, mga septic, in shock, biglang lalabas yung uod sa bibig, di ba? So they can also migrate, no? So that's letter B. That's why ang Ascaris infection, di ba, they are said to be erratic infections, no? Kasi pwede silang lumabas-labas kung saan-saan. 120, which of the following eggs is expected to float on brine flotation technique? Okay, sige. Try to analyze first. Ascaris, Trichuris, Strongyloides, Heterophyes, or letter E, Ascaris and Trichuris. Okay. So, brine flotation, basically brine, no? May salt dun sa media natin, no? So, yung sa brine flotation, it's not useful for operculated eggs. Okay? Operculated eggs are seen in flukes, right? In the trematodes, because they do not float. Okay? Strongyloides eggs, it's almost never that you're able to recover strongy eggs. Diba? How do we diagnose strongy? It's when you see the rhabditiform larva or the filariform larva, and we use the Harada Mori technique for that. Okay? It's almost never that you see those Strongyloides eggs. They come out as the larva. So that now it's now a toss-up between A and B. Okay? So Ascaris and Trichuris. What do you think? So Ascaris is and Trichuris, they're actually both almost similar, right? So probably they would both float on brine flotation technique, and the correct answer here is letter E, A and B. Okay? Pero hookworm, schistosoma eggs, they do not float. Okay? They are badly shrunken when you use brine flotation technique. So remember, Ascaris, Trichuris, they can float. So some other concentration techniques, you can either do flotation or sedimentation. So formalin ether, acid ether, no, to sediment. Then you discard, you decant it, you examine the sediments. Flotation, you can use zinc sulfate, you can use brine flotation as we just discussed. And then yung Sheeter's sugar flotation method, it's best for coccidian parasites, okay, to visualize the oocysts. So the benefit of doing concentration techniques is you're using a larger amount of stool. So in essence, it should be more sensitive, no, because you're using more sample. 121, which technique can be used to assess the intensity of infection with use of a cellophane paper soaked in malachite green solution. So this is your Kato-Katz. Okay, so Kato-Katz, it's a quantitative test. So because you want to assess the intensity. Okay, Kato-Thick, it's a qualitative test because thickness is a quality, di ba? Ganun ko siya tinatandaan. Kato-Katz, quanti. Kato-Thick, quality. Harada Mori, that's for hookworm and strongy. Diba? That's the filter paper technique. 122. Which organism is responsible for causing the coconut cake rectum? Okay, sige, try to answer. So, among these organisms, no, sino ba yung nagkakos ng associated with the rectum? Diba? Rectal prolapse. So, you have Trichuris, right? So, if you're going to venture a guess, your best bet is letter C, Trichuris trichura, that can cause the so-called coconut cake rectum. And if not to, ano naman, no, para mag-lose kayo ng appetite, but for you to really remember it, no? So, I'm going to show you an image, no? Coconut cake on the right. So, mukha siyang coconut cake, di ba? Yung mga flakes-flakes na ganun, that's actually the Trichuris organism. Okay? 123, habitat of adult schistosoma hematobium, A, urinary bladder. Alam ko, lahat kayo sasagot niyan, but it's wrong. It should be the vesical plexus. Okay? The adult schistosoma hematobium, hindi naman siya nagsiswimming sa wiwi, di ba? As a schistosoma, it's still in the blood vessels, right? The blood vessels that supply the bladder. Okay? Pag tinanong tayo, what cancer is associated with schistosoma hematobium? We need to be specific. It's cancer of the bladder, but to be specific, it's squamous cell carcinoma of the bladder. Because it could be transitional cell, right? So it's squamous cell carcinoma of the bladder. Okay, so that's your hematobium with a terminal spine over there. 124. The largest protozoan parasite of man primarily resides in which of the following hosts? So, the only human ciliate is Balantidium coli, and you see it in pigs. So that's letter C. Okay? So that's the only human ciliate. They primarily reside in the large intestine, particularly in the cecum. No, they are the largest parasite. And you would notice that they have two structures. No? You have the bean-shaped macronucleus over here, and then you have the micronucleus. Okay? So they can also cause bacillary dysentery. not bacillary, but balantidial dysentery. Okay. So next, you have a 6-year-old boy who have unilateral swelling of the left eyelids followed by fever and fatigue. Hindi nagpa-consult. Pero years later, the patient started having difficulty swallowing and abdominal pain, which prompted consult. Examination showed enlargement of the heart, esophagus, and colon. Okay, so initially, medyo hindi pa halata kung ano siya, no? But if you have a patient developing enlargement of the organs, no? Meron tayong mega esophagus, mega colon, cardiomegaly. You think of, what is this condition? You think of Chagas disease, right? So this is Chagas. It's actually the most common acquired form of dysphagia, di ba? What do you call this? Mega esophagus, di ba? So there. So it's transmitted by your triatoma bug. 126, you have a 28-year-old female who seems to have Trichomonas vaginalis infection. So the question is, what is the infective stage of Trichomonas vaginalis? Very straightforward, right? So your choices are quadrinucleated cyst, ova, trophozoid, or decorticated ova. So in general, if you're talking about the infective stage of a parasite, it's most often the cyst or the ova, right? Yung itlog. But remember, Trichomonas, we do not have an ova, okay? It's just a trophozoid. So whether it's the diagnostic stage or the infective stage is the same, it's just the trophozoid stage, letter C. So I placed that familiar table over there. It's also in your handouts for you to review and to compare and contrast the different causes of bacterial of vaginitis vaginosis. Okay, number 127, you have a 30-year-old male who sought consult because of fatigue. Pale on examination, anemic on your CBC, hemoglobin 9.5, platelet is 200,000, normal. But the MCV is, ano bang 120? Is that high or low? So that is high, no? It means to say that the cell is big, the red cells are big, so they are macrocytic. Okay, the RDW is also high. Stool examination shows operculated eggs. So basically, you have a macrocytic type of anemia. Very straightforward. Which one of these agents can cause macrocytic anemia? So that is your D-latum, no? Causative agent of megaloblastic anemia. Letter D. So this is your Diphyllobothrium latum. It has a rosette uterus. It has an operculated ova. Meron siyang parang sombrero. And what do you call this? Parang spatula yung shape ng scolex niya, no? May mga grooves na pa ganun. Okay, it looks like a spatula. Next item, number 128. You have a 25-year-old male physician who went swimming in a lake during a camping trip. Complained of headache, fever with nasal discharge. Admitted managed as bacterial meningitis. Nabigyan ng antibiotics pero namatay pa rin. So what should you suspect? No, kung ganyan, mga stagnant waters, na meningitis yung presentation, of course, it's your Naegleria fowleri. Okay? 129, agent of Cochin-China diarrhea establishes infection by which mechanism? So in short, route of transmission. Sino ba nagkakos ng Cochin-China diarrhea? So, strongy. Okay, so the correct answer here is letter C, no? Contact with the filariform larva. Remember, the infective stage of your Cochin-China diarrhea Strongyloides turcuralis is the filariform larva. Yung rhabditiform, hindi siya yung nagpe-penetrate, no? It's the filariform. 130. You have a 31-year-old female complaining of gurgling stomach. Okay, diarrhea amounting to 8 to 10 voluminous stools per day. Over the weeks, she developed weight loss, anorexia, and edema. And on examination of the stool, you have those striated shells, no? Nakita niyo yun, yung mga striations? Mukha rin siyang peanut, no? With flattened bipolar plugs, no? So the most likely organism is, ano to? So gurgling stomach, no? Meron siyang borborygmi, no? So that's actually the name of my IG na dinedicate ko for food, no? Borborygmi. Borborygmi. Diba, witty? Oh, nag-agree na lang tayo, no? So borborygmi, no? The typical sound that your stomach, not really stomach, but, no? Kung yung typical sound, no? Sa cases of capillaria infection. So the answer here is letter A, Capillaria philippinensis. So we need to differentiate trichuris egg from capillaria egg because they look quite similar, right? But the way to differentiate it is, I want you to look at the bipolar ends, no? For trichuris, it's quite protuberant, no? Nakausli. Dito flat, okay? So flattened bipolar eggs, that's one difference. Number 2, you notice here it's malinis. There are no radial striations, right? Whereas here, for capillaria, may mga radial striations over there. So that's more of capillaria egg. Okay? Other important features of capillaria, they can cause autoinfection because some female worms, they can already produce both the larva and the eggs. Okay? And that can lead to hyperinfection because the larva that gets retained in the lumen, they become adults eventually and can cause hyperinfection. Okay, so just a table for you assignment, no, to go over. Let's move on to the next. You have question number 131. You have a 38-year-old male with a 1-week history of fever and cough, initially noted loss of taste and smell, following a drinking spree because, ayan, may nakasamang friends. 3 of his friends also developed same symptoms. He was febrile, fever 38.9, desat, no? He denies chest pain, dyspnea, and other symptoms. So all of the following markers are expected to be elevated except. So what do you think is this case? Nag-fever, drinking spree. So this is baka COVID, no? So COVID. So ito, no, in COVID infection, all of the markers are expected to be elevated except procalcitonin because procalcitonin indicates bacterial infection. Okay? So guys, no, don't forget COVID. No, even if you don't have a lot of COVID cases now compared to, a few years back, it might still pop out in your examination. Okay, and it's a growing body of knowledge, so we want you to go over the latest recommendations, yung guidelines natin sa PISMID. You can look at the website. It's a living guideline, meaning to say it gets updated every now and then. So we want to keep on reading that para yung pinaka-updated information yung alam ninyo. Okay? So procalcitonin is not expected to be elevated because, it's for bacterial infection. The other markers here are inflammatory markers that are relatively non-specific. So in COVID, you expect them to go up. Okay? He developed respiratory failure. This patient most likely will benefit from which of the following medications. So, ang question kasi, saan siya pinaka magbe-benefit? If you're only going to choose one, the best answer would be to give steroids. Dexamethasone pa din. Okay? So, of course, hydroxychloroquine has no evidence. Tocilizumab, we can give it in the context of a cytokine storm. We can also give remdesivir, but the best evidence for benefit, if you're going to choose one lang, it's still dexamethasone. Basta O2 requiring dexamethasone. Okay? So, we were able to establish that early on in the pandemic. 133, etiologic agent is known to enter the host using which receptor? So, it's your ACE2 receptor. Okay? So that's why there was some confusion before, whether or not to give ACE inhibitors, diba? To those patients with COVID, it might interfere with viral infection, no? So letter D, ACE2 receptor. So COVID-19, first discovered in Wuhan, China. The key hosts here would be the bats, and the point of entry would be the ACE2 receptors. They are positive single-stranded RNA viruses. Okay, so primary host will be the bats, no? And intermediate host, it's the question mark, no? And human-to-human transmission, of course, occurs. Okay, so that's actually my last slide already. And at this point, I would want to leave you with my favorite quote. I always say this even when I was teaching, during my undergraduate years, no, as medtech review teacher. So that's already my last slide. So before we end, I'd like to leave you with my favorite quote, which has been my mantra ever since I was in college. So it's shoot for the moon because even if you miss, you'll land among the stars. So when I was in college, while I was preparing for whether it's a quiz bee, the board exam, medtech boards, the med boards, or just recently the PISBIM, ito yung lagi kong mantra, shoot for the moon, aim for the highest goal. Don't be afraid. Don't think na hindi ikaw yung achiever, hindi ikaw yung number one ng batch mo, and you have no right to aim for that number one spot. Okay? So, if you aim for that number one spot, that would really prompt you to work hard. Diba? At walang talo kung nagbigay ka ng lahat-lahat ng kaya mong ibigay. If you really study very hard, hindi ka talo. Because you might not be able to get the number one spot, but at the end of the day, you've learned a lot from the experience, and that will help you take the next big leap forward. Okay? So, in the future, papasalamatan mo yung past self mo for working really hard because that would enable you to reach your future goals. Alright? So, don't be afraid to shoot for the moon. And with that, good luck in your board examination. I wish you all the best and tiwala lang guys, huwag tayong pangungunahan ng kaba. Thank you.